Morning, Bobby. Bobby, we cannot yet hear or see you. Morning, Meg.
Hey, Bennett.
How are you?
Good, how are you?
Doing fine. Can hear. Oh, there you are. Cool.
Yep.
Thanks.
Hey, Steve.
Hi, I can't get video.
Hmm.
You hear me?
Yeah, I can hear you. You have the button is
Okay. I can't hear you.
test.
I can't see you either. Hello?
Yep, we can hear you. You're pretty dark where you are, but
Okay.
we can see you also.
Yeah, I know. I'm trying to work on that. Now I can hear you.
Brilliant.
Yeah.
Morning, Jackie. We can. I think we can hear you.
Can you hear me okay?
Yep, hear you. Can't see you by design. Good morning, James.
Good morning, Bennett. How you doing?
Doing fine. We can hear you.
Good. Thank you.
Thank you.
Bennett, Stanley's having trouble getting in. I'm checking on him.
Yeah, I'll send him a note.
Thank you. Hey, James. Hey, Bobby.
Hi. Hi,
Hey,
Nick.
Jackie.
Good morning.
Hello, all.
days in advance. I have a meeting that I could not reschedule that I have to be at right around 11 a.m. So I'm here until 11.
Hey, Jackie.
Thanks, Jackie.
Morning, Stan.
Jackie, I'm with you also. I got to be between 10:30 and 11. I could stay on this meeting till.
Do we have a quorum?
I'll stay until the vote's completed.
Okay, my system's working now. Perfect. Okay, good morning, everybody.
Stanley.
Morning, Stanley.
Right.
Good morning, Stanley.
Okay, are we ready to go?
We have 5. Bennett, do we have anyone else on the phone?
Marco just joined. Give me 1 second. If there's anyone else on the phone, though.
And Felipe is not joining us today.
Good morning, Marco.
Morning, Marco.
Good morning.
Marco.
Morning.
Morning.
So we have a couple of board members that need to leave at 11 and 11:30. So that'll give us enough time to get through. We have public comments, and then we go through the 2 variances.
Right. Yep. And then we have a COVID update, an update on the Polanco report, and CHS is going to present on their reentry planning. And that public again.
Sure.
So Stanley, I think we have a quorum.
Okay. Did you open up is the meeting open?
Yep. We are live and public.
All right. Good morning, everybody. New York City Board of Corrections, February 29th meeting. February 9th, 2021 meeting is now in session. Before we get started, wanted to just let everybody know that Jennifer Jones Austin, Chair, is not able to be with us. She has a personal matter to attend to. But she is briefed and informed of what we're going to be doing today. So our scheduled business will start by voting on the draft January 12th, 2021 board minutes, which board members have received. Want to ask a board member to move for a vote to approve the minutes.
So moved.
Ask for a second.
Second.
Are there any edits or debate? Okay, let's move to vote. Bobby?
Yes.
Steve?
Yep.
Marco?
Yes.
Yes.
And I vote yes. James?
Yes.
Okay. The minutes pass. Before we turn to today's agenda, we have a couple of announcements. The first is an update on rulemaking. As we noted at our January board meeting, the board has submitted a draft proposed rule to Department of Correction, Correctional Health Services, City Hall, and the Law Department for review and certification. We've worked through a number of complicated issues that have arisen and will submit a final proposed rule to the Law Department for certification. We expect the certification from the Law Department in the next weeks, and we'll aim to hold a special board meeting to vote on the proposed rule in the coming weeks. In advance of that meeting, we will publish the proposed rule on our website and send it to interested parties. The vote will not be a final vote on the rule, but rather a procedural step to open public comment under the city's Administrative Procedure Act. Then there will be the requisite notice period of 30 days during which public comment will be sought. We will hold public meetings during the day and evening so all who desire to comment will have an opportunity to do so. After this comment period, the board will review all feedback, consider changes to the proposed rule, and send the final rule to the Law Department for certification. Publish the final rule and then vote on the final rule. The proposed rule ends punitive segregation and replaces it with a model that prioritizes safety, accountability, support, and transparency. Finally, sadly, a person in custody passed away on January 22nd. He was 30 years old and was housed at OBCC. We send our heartfelt condolences to his family and friends. We're going to open up.
Comments?
Bobby, you said?
Yeah, I just two things. First, on the rule, I just have to express my concern that the process has gone on much too long, without adequate information to all the constituencies. And as a member of the rule making committee, I have not seen the rule that's planning on being submitted. I hope to see it soon, and the entire board should have the advantage of seeing it. Secondly, the suicide that took place is one of several suicides that have occurred in the past years of great concern to the board and to everyone who, it should be a concern to every judge who sends someone into the jails, every family family member who's living in the jails. And there was a long period without suicides, and now there have been several. Although 10 years ago, in 2011, there was a suicide in the jail where someone hung himself from the sprinkler head in the jail, and that's exactly what happened in the latest incident. And I would just ask the Department of Correction and the Correctional Health Services to review their policies with regard to suicide prevention. And as we are in the process of building new jails and renovating parts of the jail in line with the rule that I look forward to passing soon, that consideration be given to special protection for preventing suicide from hanging from sprinkler heads in the new facilities and in the revised facilities. Thank you.
I have a question.
Good, Steve.
Yeah. Have we looked at sprinkler heads being reconstructed so that they don't hold a rope, the weight of a rope with somebody's neck in it?
I think that's a question when DLC comes up, they could answer.
Bennett, is DOC on? We should be.
Yeah, I can bring them into the meeting. Give me 1 second.
I think that's something we should absolutely be factoring in the borough-based facilities, the new borough-based facilities.
Yeah, I think they're used in areas where people are mentally challenged, but this is a perfect example of somebody. I'm sorry.
Good morning, it's the Department of Correction, and Deputy Commissioner Tricia Feeney will respond to your question.
Good morning. I would like to inform you that the department does utilize institutional tamper-resistant sprinkler heads. These are used throughout the industry in DOC facilities and in mental health facilities. These tamper-resistant sprinkler heads are designed to prevent vandalism and to reduce the likelihood of attaching heavy loads in order to prevent self-inflicted injuries and suicides. Whenever an individual breaks a sprinkler head at one of our facilities, the fire alarm is activated and staff from the fire safety unit respond directly to the facility. They shut off the water supply and write the report, and then we ensure that the sprinkler heads are replaced with another tamper-resistant sprinkler head. So we are using the industry standard right now for sprinkler heads for institutional settings.
Thank you.
You're welcome.
Okay. Let's go into public comment on the department's requests for 2 variances, the young adult, ESH, and the secure units. I have a list of speakers who signed up. I'm going to call each person's name. When you hear your name, please raise your hand using the hand icon below the participants list on your WebEx screen. If you don't see the participants list, click on the silhouette of a person on the menu at the bottom of your screen. Once you open the participants list, you should see the hand icon in order to raise your hand. When you raise your hand, we will unmute you and you will be able to turn on your video. You can then begin your public comment. I will tell you when it has been 3 minutes and we will move on to the next speaker. You should limit your comments to the requested variance, so we will hold a general public comment at the end of the meeting. The board also welcomes written comment. You can email written comment to boc@boc.nyc.gov or mail to 1 Center Street, room 2213, New York, New York, 1007. I will now call the first speaker, Brandon Holmes. Is Brandon on?
I don't think he's on yet, Sam.
Okay. The next speaker is Alexandra Smith. Is Alexandra on? Yep, I see her. Okay. You're on, Alexandra. You can turn on your video. Is she able to, Bennett, is she able to, okay, there she is.
I am. Sorry about that. Are you able to see me?
Yes, we can see you.
Okay, great. Good morning, everyone.
Good morning.
I'm Alexandra Smith. I'm an attorney with the Prisoners' Rights Project at the Legal Aid Society. Before joining Prisoners' Rights, I was a trial lawyer with the criminal defense practice at Legal Aid for several years. I'm here on behalf of young adult clients to ask that the board deny the 2 variances before you today. These variances seek permission for the department to continue to undermine the health and well-being of young adults by ignoring the mandates of the Young Adult Plan and its acknowledgement of young adults' needs by placing them in extremely punitive enhanced supervision housing, where they are mixed with older adults and in its junior cousin, the secure unit. ESH was never designed for young people. And when it was designed, the board was touting its agreement to keep young adults out of punitive segregation, and later a plan to instead place them in specialized therapeutic and rehabilitative housing units with targeted programming and trained staff, the Young Adult Plan. Yet practically from the unit's inception, the Department of Correction has repeatedly sought and been granted permission to house young people and high schoolers in ESH, where they are mixed with older adults. This undermines the Young Adult Plan and also signals that the board cannot be trusted to enforce its own hard-fought minimum standards. This board has overseen one of the most cynical policy reversals in New York City corrections in the last decade. We know that many of you come from institutions and communities that protect young people, making this endorsement even more jarring. Perhaps because the abandonment of the Young Adult Plan has happened slowly with multiple variances and slow dissolution of the advisory board, this policy change has not received the attention it deserves. Where we are today is so far from the board's stated goals in its Young Adult Plan that the 2 simply cannot be reconciled. For example, look at the situation described by the department's variance request. How are we meeting the educational needs of people locked in ESH through workbooks, For a year now, we expect adolescents and with significant challenges and needs locked into an extraordinarily punitive and deprived setting to develop into adults that they need to be through workbooks. And even if these workbooks have moved to tablets, this is not education. This is not programming. This is not in any way, shape, or form the way that responsible New York City adults shape the lives and futures of young people over whom they have taken custody and therefore responsibility. Board oversight means active engagement and monitoring of compliance with its standards. For example, for the 18 young adults currently held in the secure unit, the department tells us in its request that there are 18 separate meetings held every week with each individual. Oh, may I just briefly conclude?
Yes.
Oh, thank you. With each individual youth in secure and the following 5 or 6 adults: a deputy warden of GRBC, an ADW, a captain, a CETI-CO, the program counselor, and mental youth provider.
Thank you.
In your oversight function, have you reviewed the minutes or written record of the last week's 18 meetings or previous
Thank you,
weeks?
Alexandra. We got to go on to the next.
Okay, I'll just say one last sentence if you don't mind, sorry. The young people held in the city jails need your expertise and oversight.
Thank you,
Please
Alexandra.
do not fail them. Thank you for your time. Thank you.
And you can submit your testimony. It will be, your full testimony will be part of the record. Thank you.
Thank you.
The next speaker is Francis Shapiro. Is Francis on? Okay.
This is on. If you could just raise your hand, tell us you're here, Francis. All right. I'm going to try to unmute you real quick.
I'm muted. Okay. Can you hear me now?
Yes, we can hear you. Yes, we can hear you.
Okay. Essentially, I want to follow up on what was just said, and that is to oppose the request for a variance regarding young adults being placed into the special housing units. The picture that is presented in that letter requesting the variance makes it clear that what we have right now, and even if it is attributable to COVID-19, is a situation in which the people are in a very extreme state of solitary confinement. Even the way in which the programs are described, the fact that you hand somebody a booklet and that's considered programming, that's considered a way to educate the person. We know, for example, that solitary confinement has very serious mental health effects. And among other things, it raises an individual's anger level, it raises the individual's anxiety level and depression. And you're going to just hand someone a booklet that says, okay, now learn. How well do any of us actually concentrate on learning when we are feeling full of fear, anxiety, and depression? It just doesn't make any sense. So then if we know that this situation is so detrimental to the people that we are putting there, why would you even consider continuing that practice? I'm amazed at all the times that you keep saying, okay, we're going to take care of the young people properly. But then you go ahead and each time you say, okay, we'll let you break the rules. From my point of view, that doesn't make much sense. I'm pleading with you essentially to stop damaging young people in this way. And I'm asking you not to vote positively on this variance. But since I've been talking about the issue of solitary confinement, I want to bring that up also. You know, and we've talked to you so many times about how terrible solitary confinement is for people's mental health and even their neurological health. There's so much damage that this creates. And the mayor said he was going to end solitary confinement. You're the head of a committee of 4 that's supposed to be taking that action, supposed to be presenting us with a new set of rules that are much less horrible. And you have not done that. We keep getting postponed.
You can sign up. We're going to have another.
Okay, please get the changes done, and don't let the mayor or anybody squelch what you're doing. Thank you.
The next speaker is. Okay, I see you, Tani.
Can you hear me?
Yes.
Okay, great. Good morning. My name is Tahani Dunn. I'm an attorney at the Bronx Defenders in the Prisoners' Rights Practice. I would just like to begin by asking that the board reject the variance that the department has put forth this morning. Incarceration alone has been found to seriously damage young people's mental health, and isolation on top of that causes irreparable harm. Locking someone in a cell for extended periods of time, cutting them off from social interaction, and delivering them meals through a door slot is torture. Yet the Bronx Defenders has found that DOC inflicts this punishment lightly, carelessly, and oftentimes mistakenly. If someone gets placed in ESH or solitary confinement wrongfully, there is nothing they can do. Time and again, we have identified clients who were placed in restrictive settings without a hearing or for a non-qualifying offense. By the time we figure it out, they have already spent weeks in isolation and the damage is already done. We recently learned that potentially dozens of people were placed in punitive segregation wrongfully because of a data error in entering the offense of conviction in the DOC system. We had at least one client released from solitary confinement because of this data error. Had we not uncovered this unconscionable and careless mistake, he too would have found himself in ESH for 90 days or more. This is what our clients are subject to in DOC custody. The department doubles down on the agony, they turn a blind eye to the torment, and they dig their heels in regardless of whether due process was honored or violated. The board is deciding once again whether to authorize ESH for young people. I want to tell the board about one particular client. In December, our client was going through one of the most mentally challenging times of his life. Months had gone by without receiving a hug from his mom, barely anything happening in his case. The holidays approaching, everything was becoming unbearable. We made a mental health referral in hopes of securing some semblance of help and support from DOC. Instead, DOC seized the opportunity to hail him into a hearing for a 90-day-old infraction that had already resulted in an unfounded allegation against him. What followed was nothing short of a clear abuse of power and restrictive housing placement. For weeks, DOC ignored his legal team's inquiries and complaints. To date, DOC has refused to provide proof of our client's alleged written waiver of the 5 business day adjudication rule, a rule clearly spelled out in the directives and the minimum standards. Even after they conceded that an adjudication for another nonviolent offense had been made in violation of his due process rights, he was still placed in ESH for 90 days. According to his paperwork, his placement was predicated on adjudications riddled with already established due process violations, and yet he remains in ESH shackled to a desk, grappling with the reality that DOC can do whatever they want to him, and there is nothing that he or anybody else can do about it. How can the board continue to allow DOC to torture young people without any accountability or oversight regarding who put them there and why? How can the board continue to allow young men to endure trauma for months on end? All the issues the board identified in July 2017 remain: extensive lockdowns, violations of lockout schedules, operational issues related to staffing and management, safety concerns, a general lack of engagement, and complete lack of transparency. How can this stand? DOC has proven it cannot handle the responsibility of conducting a fair disciplinary system. Repeated regurgitation of policy and procedures does not equate to compliance. The consequences of granting this variance means continued systemic abuse, unfettered autonomy, and irreversible and irreparable harm to the young men in DOC custody.
Thank you. Our next speaker is Taisha Cruz.
I don't think Taisha Cruz is on the line right now.
Okay. Danielle Gerard. Ms. Danielle. You can begin, Danielle.
Okay, sorry, I was still muted. Vice Chair Richards, board members, and Ms. Egan, I'm Danielle Gerard, Senior Staff Attorney at Children's Rights. I appear before the board each month. Once again, we call on the board to deny these variance requests. Regarding ESH, it was introduced by the department in response to the phasing out of punitive segregation, but as we have repeatedly testified, placement in ESH is equally harmful and inappropriate for young adults, as others have already mentioned. The social science and neurological research that guides best practices for working with older youth shows that young people under age 25 need both developmentally appropriate services and connections with community, not to be locked in a cell with so-called workbooks. The December 2020 ESH audit report shows the majority of lockout times to be 7 hours or less, and that lockout times could not be determined for some days because they were not recorded or the logbook was missing. There are a few notations that out of cell time was reduced due to the young adult's choice, but no one incarcerated in New York City's jails should have less than 14 hours of out of cell time. Children's Rights has similar issues with Secure Unit. First, the department seeks to incentivize progression from one level to the next by, in part, by limiting the amount of time young adults are allowed out of cell. Second, the department reports that young adults spent an average of 65 total days in security in 2020. This is just punitive segregation by another name. It would be both more humane and effective for the department to focus staff energy, programming, and resources to advance young adults' behavioral goals and personal growth before they get to Secure Unit in the first place. Finally, Children's Rights is concerned that after more than a year since the first draft rule was released for public comment, restrictive housing rulemaking abolishing solitary confinement is again not on the board's meeting agenda, nor has the rule been published, and advocates have not seen the current version. When the board does consider rulemaking, we call on you to abolish separation status housing, ESH, and Secure Unit. Once again, we urge you to require the department to develop truly meaningful programming that all young people on Rikers so desperately need and deserve. Please deny these variances. Thank you.
Thank you, Danielle. Our next speaker is Minister Dr. Victoria Phillips. Ms. V.
Can you hear me now?
Yes.
Okay, good morning. I ask that everyone else mute yourselves because it's hard to speak when you hear the playback. Peace and blessings, everyone. I am Minister Dr. Victoria Phillips, a member of the Jails Action Coalition, a member of the Justice for Women Task Force, and many other coalitions to make justice a reality and no longer just an illusion. I have been addressing this board around the ongoing barbaric violations of human rights and inhumane conditions for literally the past 10 years. After obtaining public comment, which was one of the Jails Action Coalition's greatest accomplishments, I started to speak directly to this board. Having sat on the DOC Advisory Board for Adolescents and Young Adults for 6 years since its creation, I feel knowledgeable enough to state that neither variant should be granted. We advocates ended solitary confinement for 16 to 21-year-olds, yet you, the board, allowed DOC to open ESH the very next year. With medical doctors on board, this variance continues to pass. Where is your oath to do no harm? This board has done its own reports that clearly show DOC does not follow protocol or minimum standards. Even pre-COVID, we couldn't get them to utilize the programs we advocated for with the young adults. And they always got back to me with there wasn't enough escorts. The Federal Monitor has released not 1, but 10 reports which continue to show the lack of discipline in DOC's part, a lack of accountability in real time, and let's not forget, it's been 5 years of reporting. Many individuals in DOC custody are there for less time. And let me remind this board, it was Commissioner Brand who said in the last 5 years, almost 50% of staff are new. Yet we continue to see this board pass variances to allow our community members, majority of whom are waiting their fair day in court, to be mistreated. In general population, this board will receive complaints from the inside regarding lack of medical treatment or even mental health follow-up. Do you think it gets better in ESH or secure? When will we begin to hold DOC accountable? When will they be punished for causing harm, breaking laws, or even committing murder? Let me remind you all, this board is losing funding. And just this morning, I received a call from a man who reminded me that he had 5 complaints to this board that have yet to be followed up on. This is a serious medical concern, which could even lead to his death. I encourage this board to vote no to both of these variances, and let's start to actually educate, mentor, and protect our next leaders who will surely have say over all of us in our old age. Y'all stay blessed.
The next speaker is Jennifer Paris.
Can you hear me? Can you hear me?
Yes, yes, we can.
Okay, thank you.
Thank you.
Good morning. My name is Jennifer Parrish, and I'm the Director of Criminal Justice Advocacy at the Urban Justice Center Mental Health Project and a member of the Jails Action Coalition and the Halt Solitary campaign. These variances have been granted over and over again with the assurance that you would address this situation through rulemaking. But those rules have not materialized. It is time for you to end the practice of solitary confinement in New York City jails, and you can do that today, at least for young adults, by rejecting the department's variance request. More than 6 years ago, this board went through a rulemaking process that documented just how detrimental isolating young adults is, how it affects their brain development, how vulnerable they are to the harms of isolation. As a result, your rules do not allow young adults to be placed in punitive segregation or ESH. It is time to require DOC to follow those rules rather than allow the torture of solitary confinement to continue in ESH. Not only are young adults allowed much less out-of-cell time in ESH, they are also subjected to the barbaric practice of being chained to a desk for the time they are outside of their cell. This choice between being in solitary or chained like an animal just to have some face-to-face contact with others results in young adults choosing isolation as the lesser of 2 evils. Even the department's own audit shows that to be the case. For instance, the December audit, which looks at 4 days in that month, shows that on December 2nd, none of the 6 young adults in level 1 had more than 4 hours out of cell, and 2 only had 2 hours. On December 8th, 2 young adults did not leave their cells at all. On December 15th and 22nd, 1 did not leave his cell, and on the latter date, 3 young adults had between 1 and 3 hours out of cell. Now, DOC may assert that these young adults chose not to leave their cells, but consider the choice they face: stay in their cell alone or go out and be shackled in a restraint desk all day. Please do not allow this inhumane practice to continue for another 6 months. I really don't know how you can choose not to move forward on a rule to end the torture of solitary confinement for everyone in the city jails, and instead vote to give the department permission to continue to isolate young people. It is so disappointing that this board has not asserted its independence from DOC and the mayor's office, not only in bowing to the repeated requests for this variance, but in allowing them to dictate the rules for restrictive housing, which are the purview of this board alone. And you have done that while keeping the public in the dark about your proposed rule. The members of this board must exert your independence and insist on transparency. A first step in that direction is releasing to the public the rule you sent to the law department initially, the rule that the members of this board fashioned. That way we will know just how much outside influence has affected the final rule. Thank you.
Thank you. And our last speaker is Darlene McDay.
Stanley, I believe Brandon Holmes is back on.
Oh, he's
So
back
we
on?
can take him after.
Okay. You may begin, Darlene.
Can you hear me? Okay. Sorry, I just had to go to another room. My name is Darlene McDay. I'm asking that you do not grant these variances. And I want to tell you a story about my son. This is my son. His name was Dante. This is me and Dante at one of our last visits. He died in solitary confinement in Wendy Correctional Facility, October 2017, at the age of 22. He was beaten by correction officers and thrown down the stairs. I got a call on a Saturday morning by inmates telling me that my son was beaten, brutally beaten by by corrections officers, and he was thrown down the stairs and that his face could not be recognized. The Department of Corrections tells me that then he hung himself, which I found it hard to believe. You need to start holding the DOC accountable. They've shown time and time again that they cannot make just decisions, that they cannot do the right thing. My son died in a cell by himself after he repeatedly asked to call his mom, after he repeatedly asked to speak with someone from mental health. He was denied those things. He was my only child, and I miss him every day. You can't let this keep going on. In the Commission of Correction report done on my son, it stated that the officers lied on official paperwork, that they falsified paperwork, but yet they're still working to this day. Something is wrong with this system. My son should be alive today. I should be able to hug my son, to talk to my son, but he was denied any type of comfort from his family or support. This cannot be done. People need support. They need people. My son was a person. This is Dante. I want you to look at him. Look at his face. Please don't make him die in vain. You cannot pass these variances because it gives them another tool to torture people. And people need to stop being held in solitary confinement. They said that my son smoked something. That's why he was in solitary confinement, kept away from his family for 3 months. Most people that maybe abuse drugs are usually people that suffer from mental health problems. They suffer from depression, and they're looking for a way to make themselves feel a little better. A 22-year-old child, a little boy, he barely got to live, and they took away his life. And to this day, they get to work, they get to see their family, and I get to suffer because they don't answer any questions. And the state and the AG that decides that they're going to protect these people, it's unbelievable. It's unbelievable that anybody can let this go on anymore. And I see so many people that they say committed suicide, but that's their way out. Why was my son's face bashed in, and why couldn't he eat? They had to call for pureed food because his face was bashed in. And they had to he couldn't see because his eyes were swollen shut. So if you put another person in this position, you are just as bad as they are. Because no one should have to live like this.
Thank you, Darlene. And our condolences. Thank you for sharing your pain.
I understand that, but I just wish that they would do something real.
Thank you.
Because people suffer and families suffer and communities suffer, and it needs to end.
Thank you. Your story is a sobering story of the work that we all need to do. Our final speaker is Brandon Holmes, if he's on. Thank you. You may begin, Brandon.
Thank you. I think much of what I wanted to comment on has been said, but I want to reiterate that right now, in our communities, it feels like this process for rulemaking has been tainted, that the mayor made this grandiose announcement that the board and the DOC began to collaborate on something that the DOC never wanted to see happen. And we have waited and waited and waited, in many of our cases, a decade, in my case, maybe 3-4 years, to see these changes happen. And the confidence has waned in BOC. I do not have confidence in this oversight agency and this branch of what seems to be kind of curtailing or bending at the will of the Department of Corrections when they are historically at their worst, with the least people in their custody, with less facilities to oversee, but violence soaring every day, with deaths continuing to happen. And I want to honor the Cruz family, who is not able to make it on this line today, but Taisha Cruz and their family for starting to come to these meetings, because people's loved ones continue to die in our city jails. And we continue to give rule exceptions or variances to make up for the shortcomings of this Department of Corrections as their workload gets lighter and lighter, but the culture of violence and torture gets deeper and deeper. I want to ask you again to release the proposed rule that the board and this working group developed to protect your role as an independent board, and also to allow for some accountability and transparency to show through your work, and to stop granting variances that will continue to step in the way of any of your legacies or the legacy of this administration, which many of you have joined the board with. And while we have, new folks, I want to speak directly to these new folks who are joining the board, especially Marco Carrion, who has been somebody who has communicated with advocates in the past around the process of closing Rikers, and what that looks like, how communities are engaged in that. Please improve the way that you actually distill the information that comes through these meetings, through these public comments, through testimony, and turn that into action. Not a projected timeline that is going to propose rules to end solitary in September, then October, then February or March. Please distill the information as we show up tirelessly, as families show up and tell you their tragic stories when their only children are taken from their families. Turn that into action. Thank you. I yield my time.
Thank you, Brandon. That concludes the public comment for the two variances. We'll now go into the variance. Meg?
Sorry, give me 1 second. Apologies, slow computer. Okay. The board first granted a variance permitting the department to house young adults in ESH in July of 2016 and has consistently renewed it. This current variance was last renewed in November of 2020. As of January 25th, there were 20 young adults in ESH, 6 in level 1, 9 in level 2, 5 in level 3, and 5 in level 3. This marks an increase of 300% compared to December 1st of 2020, when there were only 5 young adults in ESH. The average length of stay in ESH for the young adults who left ESH between August and November of 2020 was 89 days. The median length of stay was 71 days, the minimum was 23 days, and the maximum was 167 days. 3 young adults spent time in a restraint desk unit between August and November of 2020. 1 of these young adults was placed in a restraint desk unit 3 separate times during the 4-month period ending November of 2020. These 3 young adults spent an average of 11 days in a restraint desk unit. The median time spent in a restraint desk unit was 14 days. The minimum was less than 2 days, and the maximum was 16 days. All 3 young adults who spent time in a restraint desk unit also spent time in ESH levels 2 and 3. 2 of these young adults spent most of their time in ESH outside of a restraint desk unit. The young adult with 3 distinct placements in the restraint desk unit spent most of their time in level 1. 73% of the reviews conducted between August and November of 2020 resulted in a recommendation for progression. I will now ask the department to present its variance request.
Good morning, all. This is Chief Stutes speaking, New York City Department of Correction, and I will be presenting this morning on our enhanced supervision housing variance regarding young adults. But pursuant to Section 1-15F of the New York City Board of Corrections minimum standards, the New York City Department of Corrections requests a 6-month limited variance renewal from board minimum standards, Section 1-16C1II, which requires that young adults ages 18 to 21 be excluded from placement in enhanced supervision housing, commonly referred to as ESH. The department requests this renewal to take effect on February 21st, 2021, the date upon which the current variance is set to expire.
Okay, we're gonna want to move to vote on the requested variance. So can I get a motion to move?
Stanley, we're voting on the youth now?
Yes, the one that the chief just presented.
Okay. Okay, clear then. Thank you.
Can I get a motion to accept? No motion to accept. This is a motion to accept. Get into debate. Without a motion, the first variance will not come up for a vote, will not pass. The motion does not pass.
I understand what they said, right?
We need to go to the second variance, the secure variance. Meg?
Yep. This variance request is for the secure unit. The board first approved the secure unit variance in May of 2016, allowing the department to limit lockout to 10 hours instead of the normal 14 hours and provide legal resources in the unit. The variance was last renewed in November of 2020. As of January 25th, 2021, 9% of all young adults in DOC custody were housed in a restrictive housing unit. This includes secure ESH or a structurally restrictive unit. 4% were housed in secure. 5 were in quad 1, 5 were in quad 2, 3 were in quad 3, and 4 were in quad 4. From August 2019 through early July 2020, the proportion of young adults housed in secure increased from 2% to 6%, while the total number of young adults in DOC custody decreased. As of January 25th, 2021, 4% of the young adult population in DOC custody was housed in secure. By November 30th, 2020, DOC had placed 204 unique young adults in secure, bringing the total number of placements since the secure unit opened in June of 2016 to 275. From August to November 2020, there were 31 exits from secure, down from 38 in the previous 4 months. Most of the exits, 61%, were due to the young adult completing all phases of secure. Most reviews result in a recommendation for progression. However, the proportion of young adults who received recommendations for progression decreased 7% compared to the previous 4 months. 81% resulted in progression, down from 89% in the previous 4-month period. The average time in placement for the 25 young adults in secure as of December 1st of 2020 was 49 days, down slightly from an average of 51 days for young adults in secure as of August 1st. DOC reports that between May 1st and October 7th of 2020, 38 young adults housed in secure had received a tablet. 72% of all unique young adults in secure over this time period. As of November 30th, 2020, 10 in-person programs were offered in secure. And between August and October of 2020, young adults in secure had access to 3 in-person programs: community meetings, individual counseling, and follow-up sessions for self-guided materials. In November 2020, an additional 7 in-person programs became available: anger management, dialectical behavior therapy, goal setting, individual counseling, interactive journaling, interpersonal skill development, and young men's work. I will turn it now to the department to present their request.
Good morning. Again, this is Chief Stu speaking. I will be presenting on the department's behalf with requesting the variance regarding the secure unit. Pursuant to Section 1-15F of the New York City Board of Minimum Standards, the New York City Department of Correction requests a 6-month limited variance renewal of DOC Minimum Standards, Section 1-05B, lock-in, and Section 1-08F, access to courts and legal services. For the purposes of monitoring the use of secure unit, the department requests this renewal to take effect on February 25th, 2021, the date on which the current variance is set to expire.
Thank you, Chief.
You're welcome.
Again, ask for a member to move to vote on the requested variance for secure.
Stanley, I'll move to vote on secure.
Second? I second it. Let's open the floor for debate and conditions. If there are existing conditions, Meg will read all existing conditions. Existing conditions are considered a package.
Do have conditions on secure. I can read them now. Condition 1, restraints, including restraint desks, shall not be used except to control an incarcerated person who presents an immediate risk of self-injury or injury to others, to prevent serious property damage for healthcare purposes or when necessary as a security precaution during transfer of transport. When restraints are necessary, the department shall use the least restrictive forms of restraints that are appropriate and should use them only as long as the need exists, not for a predetermined amount of time. Condition 2, the department shall not use restraint desks in secure units except in the secure unit school area and only when extenuating safety or security circumstances or specific credible intelligence of a safety or security threat require their use. And the deputy warden of secure approves their use in writing. The department shall notify the board in writing every time restraint desks were used and specify the circumstances that required their use. The department shall provide written notice to the board within 24 hours of such occurrence. Condition 3, the department will make every effort to increase the number of staff present and supervising young adults during secure unit school sessions and keep the number of students to a safely manageable number without restraint desks by adding multiple school sessions if necessary. Condition 4, the department shall not use 3 or more point restraints in secure units. Condition 5, the department shall provide all young adults housed in secure units with a minimum out of cell time of 10 hours per day, except for instances of de-escalation as set forth in the department's written directive concerning secure units. Provide all young adults with due process in connection with their placement in secure units and exclude all young adults with serious mental or serious physical disabilities or conditions from placement in secure units. Condition 6, the department shall notify the board in writing every time the lockout period in secure units does not start at 5 a.m. and the reasons therefore. The department shall provide written notice to the board within 24 hours of such occurrence. Condition 7, during the pendency of this variance, if the young adult in a secure unit has not committed an infraction within the preceding 28 days, the young adult will advance to a less restrictive unit level or unit unless he has engaged in disruptive, violent, or aggressive behavior while in his current level and or there is credible intelligence that he may engage in additional violence in a less restrictive unit. Condition 8, where the department is permitted to consider young adults' activity occurring or actions committed prior to the incident, such activity or actions must have occurred within the preceding year. Condition 9, the department shall conduct and report on a monthly audit of its compliance with BOC minimum standards and education services. Section 1-05B, lock-in, specifically the number of out-of-cell hours per person. Section 1-08F, access to courts and legal services, including law library. Section 1-06 recreation and section 1-02C2 classification, specifically the number of programming hours offered to each young adult and the number of hours each young adult participated in programming. And education services, specifically the number of young adults DOC brought to school and for each young adult, the time DOC brought him to school and the time DOC took him out of school. The department shall provide its monthly audit report to the board by the 10th business day of the following month. Condition 10, the department shall provide the board with a public report on the implementation of the foregoing conditions. The requirements for this report are outlined in a document titled ESH and Secure Unit Variances, Public Reporting Condition dated November 23rd, 2018, and available on the board's website. Condition 11. On at least a monthly basis, the department shall provide the board access to all documentation considered in each secure placement and review decision. This includes, but is not limited to, all records reviewed or created by secure unit adjudication, health and hospitals placement review, the chief's reviews, and the secure unit support team. On a monthly basis, the department shall transmit to the board a list of all secure placements and reviews. The department shall provide this documentation for each month by the 10th business day of the following month, except documentation for the month this variance expires shall be provided by the 5th business day of the following month. And those are the conditions.
Thank you, Meg. Would someone move to vote on the conditions?
Moved.
A second?
Second.
We asked if DOC would like to comment on the proposed conditions.
No, we accept the proposed conditions.
Okay, let's start the vote. The conditions will be considered as part of the package. So let's do a roll call. Bobby?
Bobby, you're muted.
Yes, for the conditions.
Jackie?
Yes.
Steve?
Support.
Marco?
Support.
James?
Yes.
And I support. Now we're going to vote for the conditions and the rule. Let's do roll call. Bobby?
Yes.
Jackie?
Yes.
Steve?
Support.
Marco?
Yes.
James?
Yes.
And I vote yes. The variance and the condition both pass. We're going into the coronavirus. Meg?
Yep. Just give me 1 second. So we've asked the department and CHS to provide a response, or sorry, an update on the response to the COVID crisis. We continue to applaud the work of DOC, CHS, and people in custody to mitigate the spread of the virus. We remain concerned about the infection rate across the city and in the jails. We are particularly focused on the rising jail population and housing area density, and have been working closely with the city and other stakeholders to ensure that these concerns are addressed. As cases remain high in the community, among staff, and among people in custody, a comprehensive testing strategy becomes increasingly critical. As we did at the January meeting, we will now specific issue areas that we would like to discuss. First, the increase in confirmed cases. As of January 29th, 9% of the jail population had confirmed COVID infections. This includes active and recovered patients. The total number of COVID-19 patients in custody, active and recovered, is now at 509, its highest number to date. The number of active infections among people in custody reached a recent high of 100 on Monday, February 1st, with CHS reporting 87 active infections as of February 7th. CHS attributes this fluctuation to people being cleared as not having an active infection, and to a lesser extent, discharges. Also concerning, cases among staff continue their steady increase. As of January 29th, the cumulative count for DOC staff was 1,759, and for CHS, it was 262. Since December, DOC has reported 258 new staff cases, accounting for 37% of all new DOC cases reported since May. And CHS has reported 44 new staff cases, accounting for 48% of all new CHS cases reported since May. Next, decarceration and housing density. The total jail population continues to increase at a concerning rate, with the jail population reaching 5,317 as of January 29th, which is a 39% increase since the end of April. As of yesterday, February 8th, the population was 5,390. As of Friday, January 29th, New York City's jails held 4,744 people in pretrial detention, 152 people serving a city sentence, 233 people held on technical parole violations with no open case, 188 people in custody for other reasons, i.e. they were state sentenced or state ready, 794 people age 50 and over, and which included 54 held solely on a technical parole violation. At our January meeting, we discussed the city's efforts to reduce the jail population. We continue to stress the inherent risks of jail during this pandemic. They're transient, dense, congregate residential settings with thousands of staff members coming and going every day. We also noted the housing area density concerns partially due to the increased population. We believe that decarceration is a critical component to any virus mitigation strategy. Board members, board staff, people in custody, the defense bar continues to raise concerns about this increasing population and housing area density and higher density housing areas, thus further preventing social distancing. The CDC guidance to correctional facilities recommends that if space allows, the agency provides space between individuals' beds, ideally 6 feet in all directions, and minimize the number of individuals housed in the same room as much as possible. While we continue to see some improvement by the department, our concerns remain. Since October, the proportion of the jail population in units above 50% capacity has decreased by 20%, from 82% on October 31st to 66% on January 29th. Between January 23rd and January 29th, the average daily population in housing areas above 50% capacity was 3,321, which is 66% of the average daily population in custody, with 34% of the ADP, or 1,697 people in a unit above 75% capacity. As of December 30th, 2020, and without accounting for operational or individual specific security factors, board staff estimate that to achieve 50% capacity level across all general population housing areas, the department would need to rehouse approximately 809 people in general population units that exceed 50% capacity. That's 445 in cell units and 364 in dorm units, and open a minimum of 19 general population units. An additional 45 people in mental observation units and 55 people in protective custody housing would need to be rehoused to achieve 50% capacity in those units. I will now turn it over to the board members to pose any questions to the department or CHS on population or housing area density.
Thank you, Meg. A question for the Department of Corrections. What is the city's plan to reduce the jail population, to continue to reduce the jail population as it's been escalating?
Well, Stanley, as you know, we are limited to what the population that the courts commit to us. We review our city sentence population, which is at about 161 as of yesterday for the participation in 6A release programs. And so that's where we are. We're really dependent on the courts and how they commit individuals to our custody.
Have y'all been in communication and coordination with the courts, district attorneys, encouraging them to use alternatives or diversion or doing release? Have you had any communication with them?
So the communication we have with the courts is almost daily. It revolves around increasing court appearances, video participation. Our video court appearances has increased dramatically, and we feel the more an individual gets before a judge, the better it is to resolve the criminal case.
Question on housing. Late last year, there was a meeting with City Hall some board members attended, where we were told that there would be a program to decrease the population. There has been no program to decrease the population. I think it's worthwhile pointing out that that every week the population increases by about 100 right now, requiring at least two or three additional housing areas. A year ago, right around this time, when the department, when just a month later from now, when COVID, the pandemic came to the jails, everybody worked together, beginning with a population of exactly what we have today. The city and the DAs and the judges and the police department work together to decrease the population. Now there's no effort being made. The policy in the city government, which used to be to try to get to smaller jails and reduce the population in general, has been reversed by a new policy led by the police department, which seems to say that the problem in New York City is that too many people were being released. The head of MOCJ is no longer there. They're absent from any discussions. I think the increase in population during this time is inhumane and dangerous, and will accelerate the pandemic. I understand the department can do limited efforts in this, but the last time you were very, very active in trying to get all the parts together, and now that's not happening at all.
Thank you.
I guess I have one other question about what the consequences of this increased population, as you were mentioning, Stanley. How does the department? Last month, the department said that they could not decrease the density of dorms because there was not enough staff. Now the number of dorms required is dramatically increased because the population has gone up about 300 or 400. Is there staff now to care for all the people who the police are bringing into the jails, and to provide for separation? Does the department have any plans to achieve 50% capacity? And do they have enough staff to do it? It's to the department.
DOC, do you want to respond to that?
I provided a response last month. The statistics on the staffing levels have not changed. We can only do so much with releasing people to the 6A program. We will manage our housing units as appropriate, the staffing levels that we have, and ensure safety for everybody in our jails. My position has not changed since last month.
Well, my question was, given that the population has increased substantially from last month, are you still, at what point will you, if the population is increasing 100 a week right now, at what point will the department be overwhelmed in terms of the capacity, or will the plan just be to increase the density in the housing areas?
If you recall, I told you last month I could not commit to 50% population in the dorms because of our staffing issues. If you recall the testimony of Dr. Ross, he said it's not about density, it's about people who are not sick living with people who are not sick. That density is not as important as other factors. And over the past month, we have opened up additional 16 housing units. That's a 7% increase. So we have now 252 housing units open, when on December 31st, we had 236.
I understand that you're having to increase the number of units because you have an increased population. Everybody else is concerned about density in the country and the world. But now you have an asymptomatic and exposed unit in the infirmary as well.
We have not changed our housing strategy. And if CHS would like to respond to that, I will defer to them.
The CHS, would you like to respond to that question? We are going to go into testing and vaccines.
This is about housing.
I know.
We did have one exposed housing area in the infirmary, not symptomatic, and follow-up testing of the asymptomatic people in that area has been negative. We haven't found additional cases.
Do you have a policy of having over 50% housing within the dormitory area?
For the infirmary, is the question specific to the infirmary?
All the NIC infirmary areas, the medical housing in the NIC.
No.
You limit it to 50% there.
I said we do not have a policy on that.
So it's okay with you if in the infirmary areas that the population goes above density of 50%.
I think it's essential that we be able to provide the level of care that patients need, and the infirmary is only so big, so we can't commit to that 50%.
Okay, there are no other areas that you could. The department's opening up areas all over the system. Can you open up additional areas as well?
Bobby, I think you know that the kinds of physical plant that are needed for that population are very specific, and there's not opportunities to open additional infirmary housing. We do have the use of NIC Maine as well, which has helped us cohort vulnerable patients. And I would also point out that these are areas where we've been very active in offering vaccination.
Okay, thank you. I'll come back when we have the vaccine discussion.
Yeah. Meg?
Sure. We'll now turn to of staff and people in custody. CHS reports as they presented at the January meeting that the plan to manage the second wave has not changed. They continue to test all new admissions regardless of symptoms and other patients at other times for surveillance based on contact investigation symptoms or upon request. DOC continues to provide on-site testing opportunities and information to staff. They're also providing transportation to and from jails and testing locations and backfill staff so that testing can occur during the person's tour. The department did not provide any more information on mandatory testing for staff, but noted that they continue to work with the administration and other stakeholders to ensure adequate testing. The COVID-19 testing rate increased from November to December of 2020. Since December, there have been 2 to 3 tests administered for every 100 people in custody. CHS reports that the testing turnaround time for all tests during the week of January 25th to January 31st was 0 to 3 days, and the refusal rate from January 16th to January 31st was 0.8%. From June to mid-November, the rate of positive test results remained below 0%. As of January 24th, roughly 16% of tests administered by CHS were positive. I will now turn it to the board members to pose their questions.
Steve?
Mike, could we have a clarification on the last point you made? Testing positivity, what was that you said?
16% of the tests administered as of January.
No, that's not
That's not
that's way
consistent
high.
with our numbers.
It's at least twice.
Yeah,
Maybe
you might
3
have
times.
added our numbers together for something.
Have 8%? Is that what you're saying?
Our overall positivity rate is 3.69%, which is less than half of the cities, which is 8.28. Our new admissions tests is 1.87% are positive. Our non-new admissions is 7.41. I'm not sure how you get to 16, but
Okay.
none of those
Well-
additions work.
Yep, we'll look at it. Thank you. Sorry about that.
Steve, would you like to open?
Sure. I just want to quickly go through the essence of a letter I wrote over a week ago. And the letter went to CHS, to corrections, to the mayor's office, everybody on the board, and a number of other people. The silence in response to it, I find disturbing in and of itself. And we can leave that for a second. What is truly most disturbing to me is, and I just heard the numbers and I heard, some dispute about how many people and so forth. I think we're underestimating what is essentially a rise in a confined circumstance. And if one was to sort of think about this and where it has been very similar, it reminds me of the nursing homes. And we were very quiet about the nursing homes and not on top of them at the beginning. And I don't need to tell anybody what that has turned into, okay? In general, we have been making a pathway that is positive in the state and the city, but I think that we are stuck here a bit. And the lack of, everybody has an answer to a question and the answers don't fit with the other people's response, in my opinion. So just to be very concise here and not go on, I tried to focus on 5 different areas that I think are most important. And this is not rocket science. This is what, everybody knows and has learned, okay? Vaccination is behind, but we're starting to catch up. But I see nothing different between this circumstance and the nursing homes. And we should be advocating for more than the providers of care to get the vaccine. As an example, I think all officers and others that are working in the facility should get the vaccine. For the same reason that we're giving it in the nursing homes and trying to prevent another problem there. And I don't have a clear response to that. And some of the responses that I've gotten have been off the record, but people are saying lots of the officers don't want to take the vaccine. We need to get to those people and educate them and get them to realize that they're in potential danger themselves and their families and their friends. So I think universal vaccines in this environment should be more and should be, we should be looking to do that rapidly. I said this a million times before. Ross, you just explained what the testing is showing now. I don't think the testing is as comprehensive and is not as useful because of the way you're doing it. And I won't go into it. We've talked about this. You need to do more than PCRs. I know you've done some antigen testing. They need to be going all the time. And the antigen testing gives you the answers to questions, albeit sometimes false positives, in those first 5 to 7 days. Those first 5 to 7 days in somebody who doesn't look sick at all can be devastating. And I think we need to use that, and we need to really bring that up to par. I think we should, and we're watching this and going, well, the courts and this and that. We need a comprehensive attempt to bring the number of people in custody down, not up. And we're going in the wrong direction. And, we've had a little discussion on that just as we go. Bobby's questions, other people's answers. As far as I'm concerned, it makes it very hard to keep people 6 feet apart. And in a facility where people are moving around and so close to each other. And again, it's like a nursing home. We're watching a disaster happen in front of our own eyes. So we need to decarcerate, or if we don't, we need to open more facilities so that people are spread out more and not near each other, so that they can be 6 feet apart. I have no question in my mind if we said everybody has to wear a mask. Everybody that comes in, everybody that's there, that it's something that we have to support. It's as important as everything else that you've asked us to do and asked us to do over and over and again as you work to make it better. They need to wear masks, and they're not doing it. And it's not universal. And again, with the 6 feet apart, that has to be universal for what everybody's doing at any time, any place. I did get a call from Joseph in the mayor's office, and he was he wanted to get together. That has never happened. Okay, and what we're watching now is the opposite. It seems that the mayor has said that we don't need to vaccinate all these people. I think that's dangerous and wrong, and we're going to see a lot of very bad outcomes as we move forward. So I wanted to keep it short. I kind of can't believe that people that I've known forever have not contacted me to talk about this. Because this is a disaster in the making.
So I think I'll fold that into two questions. One for CHS. Could you speak to what Steve is talking about in terms of testing? We know about the testing for new admissions, but what about the testing in general pop? And what about the 2 tests that Steve spoke about? And then the question for DOC around mask compliance for people in detention and for officers.
Can
I think you should take testing.
Sorry, can I just add one point, Steve, to your comment about the city not being back. They are circling back to set up some time to talk. So we will make sure that happens ASAP.
Thank you, Meg.
Sorry, I just wanted to clarify that.
And Steve, if you have more points than that, you want them to speak to it. I know you and I spoke. What you really want is action. You don't want conversation.
I want cooperative action that's clear that people are working together, because this is the most important thing that's happening at this moment.
You got it.
And everybody can't have a different view of it, or I can't do it. They're on the issues that will predictably lead to unnecessary deaths. We need to be together.
Yes.
And it should happen in a day.
So CHS, would you like to speak to that?
Sure, this is Ross McDonald. So Steve, thank you for that. And as Meg said, that's our understanding of where it is, that there is a plan to follow up. We appreciate the content of the letter. I think that a lot of what you're saying really resonates with CHS's and DOC's plans from the beginning. We have advocated for decarceration, and absolutely when I'm saying that the narrow focus on a particular housing area being overfilled should not be for DOC and CHS to answer. It's really a decarceration question, because if there are so many people in the system, then our options are limited because of physical plant and other considerations. I also mentioned last time that a lot of our COVID response efforts require additional staff work on the part of both DOC and health staff. And those things are tremendously important to implement. And again, you know, the density of a particular housing area just has to be seen in that context. It's not that it's not important, but it really is a decarceration issue, which has been part of our plan from the beginning. So we have broad agreement on, I would say, virtually everything in your letter. The one area where we have disagreement is on the question of testing. And there are really technical and scientific reasons that we seem to be reading some of the medical literature differently than you on some of the specifics with regard to testing. What I think we do agree on is the need for aggressive asymptomatic testing, which we have been doing, guided by the epidemiology, as we've said all along. And the data that Meg presented, though the y-axis seems strange to me, demonstrates, you know, roughly a threefold increase in the rate of testing since November, which is really responsive to the increased number of cases that we're seeing. And so, you know, we have broad agreement, and I don't see, you know, other than the specifics of the testing, which we'd be happy to talk through when the time comes for that. You know, broad areas of disagreement. These are our critical strategies that we have been using. You know, I don't want to minimize the transmission that we've seen. We certainly have seen the cases go up. But there are also a lot of factors that need to be looked at that give us some hope. One is the fact that we are pursuing vaccination, particularly for our most vulnerable populations. One is that there is a reserve of immunity in the population, so that vaccination is augmenting that. And another is that because of the aggressive testing that I mentioned, the rate of asymptomatic disease is much, much higher than it was in the spring. And, you know, for every case that we're finding now, it's probably equivalent to a factor of 5 or 10 cases that we were missing in the spring. So if you are just comparing those numbers, you know, they're still much lower in terms of cases identified than they were. But even so, when we look at the clinical disease behind those cases, it's night and day compared to what it was in the spring. So again, not minimizing, and very clearly advocating for decarceration as we have throughout. Just understanding that the situation is different in many ways from what it was in the spring.
Russ, are you in favor of the corrections officers and other people working there having the vaccine now?
Absolutely, 100%.
And you're advocating. So we've both lost on that one, if I'm reading what I hear from the mayor. Press conference.
Steve, it's Patsy. I just want to, I didn't realize this was going to be the format today because since the January meeting, the board sanctioned CHS for not coming right out and reporting numbers and updates. So I'm going to do that now, even though it may be out of order. As the board knows, CHS daily reports statistics to the board. Those were some of the ones that Meg recited earlier. I will tell you that those numbers, instead of 509 ever positive, were at 511 as of yesterday. That's a one-day update. You'll get that number later today. Our active cases, patients were 87 on the 7th and are 91 on the 8th. I just want to make sure everybody understands that. So we're doing what we were asked to do. Again, I noted earlier that our positivity rate, 7-day positivity, is 3.69, which is less than half what's out in the city. I will report again that, as Ross said, we've been continuing our decarceration efforts. As of January 31st, we have advocated release of 2,989 patients. 54% have been decarcerated, and these include 1,800 patients in the last 2 months. On vaccine, I advised the board in January that CHS, New York City, because of CHS's efforts, is the first correctional facility and is still the only jail in the entire state of New York to offer vaccine to any patients at all. As I advised back then, we did that by arguing successfully with the state that certain of our patients were clinically analogous to residents of state-operated facilities overseen by DOH, OPWDD, OMH, and OASAS. We have since then, and we began those vaccinations on January 6th. Again, we were the first. We had December 28th, the week prior to that, begun vaccinating our staff, having secured approval from the state that correctional health services staff were in fact healthcare workers. We did not get that up front. So December 28th, we started vaccinating CHS staff. January 6th, we started vaccinating our patients. When the governor opened it up to 75 plus and 65 plus, we aligned immediately with that and began extending to patients who are of those age groups. On January 12th, January 11th, the governor announced 1B category, which includes DOC. In recognition that the city wasn't ready to do that, CHS stepped forward because of the importance of DOC and our partnership with them and the health of the COs. We voluntarily stepped forward on the next day and began offering vaccination to correction officers. And we did that for 2 weeks while the city got a vendor in place. So we very much agree that vaccination is critical. It is the groundbreaking, the life-saving, the pandemic-breaking step. Vaccine hesitancy among our staff, among DOC staff and our patients is really no different than what is outside in the community, in the country, in the world. But our efforts to educate people has been in person, going to housing areas, talking to patients in clinic, talking to our staff. We have webinars. We have written, paper flyers, electronic information, constant emails about why it's so important to sign up for a vaccine. And we continue to do that, but I don't think we're unusual in that. So that's my required update to you.
Patsy, what's the uptake on vaccinations for CHS staff and for those detained people who are eligible?
So our staff is about 39%, and the patients' numbers vary, but over 48% of the persons 65 and older have been vaccinated, have received vaccination already, their first dose. And second dose acceptance is pretty good.
Mm-hmm. Thank you.
Yep.
Bobby?
Bobby, I think you're muted.
Muted.
Excuse me. Thank you, Patsy, for that update. I appreciate, more than appreciate, what the efforts of of CHS and DOC to get the vaccination process started. But I assume that we are in agreement that the policy of that the need for vaccines in the jails is different than the need for vaccines in other settings. Everyone in the jail who works and lives there should be vaccinated because of the high risk of transmission, the inability to protect yourself from transmission, and the positive effect that will have on the community as well. The governor, as we know, has been weird, I would say, in his neglect of the people who are locked up. I mean, it's good to give vaccine to OMH and and Oasis, as you talked about, Patsy, but he's been terrible in terms of providing it to other populations. I know that you work specifically to get it for the vulnerable population. There are a lot of more. I assume that there are more vulnerable people than 500. Is the mayor going to ask for vaccine to vaccinate everybody in the jails, or is it just going to be for the most vulnerable population? I would hope that your epidemiologic understanding is that the risk is such that it should be for everyone. I agree with the point Ross made that whether you documented it or not, there was a mass infection of the staff and the and the people who live in the prisons in April and in March and in May, and that gives a baseline immunity which is helpful to prevent some deadly disease. But shouldn't everybody be vaccinated? Isn't that the clinical approach that we should take, that it's all people who are locked up in the New York City's jails should be vaccinated, not the most vulnerable? That's my question.
Yes, Bobby, I also mentioned in the January meeting that we had been continuing since December, actively advocating that everybody who's in the jails should be offered vaccine. We're glad that the governor announced on the 5th that effective next Monday, that people with certain comorbidities and underlying medical conditions can also be eligible. I said in January that we continue to advocate for everybody who's in the jails, regardless of underlying or health conditions, but because of the nature of the congregate setting, should be offered vaccine. In fact, I believe I'm quoted in a lawsuit having said that.
I think you are too, and you're right. But I heard the mayor talking about this, and he doesn't seem to take the same position as CHS does.
He was the opposite. But I mean, that if I heard it correctly.
You're not the mayor, but is he in disagreement on this issue?
I have not.
Well, it would be very helpful if the mayor would directly approach the governor and ask for everyone in the jails to be vaccinated the way you have, Patsy. Thank you.
A question, Patsy. Being that the governor expanded the criteria, do you know how many people, based on that new criteria, will be eligible of the detained people, or that's a work in progress?
That's a work in progress. We'll let you know. We started this exercise 2 days ago.
Okay, thank you.
Yep.
And we really do appreciate your advocacy and encouragement on the state level to expand vaccines to everyone who is detained. Been calling for that from the very beginning, and we really appreciate it. We're gonna move on.
Stanley, I think the direction could have an opportunity to address some of the issues put out that are relevant.
Yes, please.
So, thank you. First of all, there have been months where you have given us accolades for our success, and then another month where you vilified us for what you believe we haven't done enough of. And I am completely baffled by the board's vacillation on this topic. With regard to the letter that we received, we are crafting a response that's not redundant of the facts that we give you. So we have been open and transparent about everything that we have been doing in the jails for almost a year now. We report to the board and the SCOC daily, and we post those data points on our website. We have been one of the most successful correctional systems in the country with our housing strategy, our serious illness. Unfortunately, we had 3 deaths early on in the pandemic before we knew what was in our jails, but that was the only 3. It's my understanding we don't have anybody in the hospital and haven't had anybody in the hospital for quite some time. So when we keep getting the same questions about density and strategy and housing, it is beyond me why you don't see that data as something positive and continue to pick at little things that you think we should be doing differently that might alter our success. With regard to the vaccine, there is an extraordinarily high number of medical professionals across this city in the hospitals who have not taken the vaccine. And the physicians on the board know better than anybody that individuals have the right to decide their own medical treatment, whether we like it or not. And I'm sure as physicians, you have had patients who have declined your advice and your medical course of action and made a decision for themselves. Taking a vaccine is no different. Taking a vaccine is a medical choice. Would I like everybody to take a vaccine? Yes. Almost everybody in this room has and has had their second dose or is scheduled for their second dose. But I don't get to decide that, not for my staff and not for the people in our custody. With regard to mask compliance, those in our custody, it is mandatory for them to wear masks when they are outside of their housing unit or while they are engaged in a group program delivery. If they do not wear their masks, they cannot leave the housing unit and they cannot engage in programs. If they are within the housing unit that they have been living in with other healthy individuals, they're allowed to take their mask off. With regard to staff, it is mandatory that they wear their masks. Since, for the past 168 days, when we implemented the policy that non-mask wearing individuals would be dealt discipline, 220 staff have been disciplined for PPE violations. And we have real-time monitoring, video monitoring at the cask, who when they see a violation, they call that housing area or that corridor or wherever they happen to be to correct that violation. So we are doing everything that we possibly can do. We give advice to other correctional institutions around this country because of our success. And prior to us stopping on this topic, I'd like you to hear from SDC Linnell McGinley-Liddy with regard to the efforts that she has been involved in managing the vaccine and the testing delivery on Isle.
Good morning, everyone. I just want to start out by saying we started a month later than CHS, and we have vaccinated about 10% of our staff. The department, continues to provide convenient on-site opportunities. And we remove our barriers by providing transportation, dedicated transportation to and from the jails. And we also provide an opportunity for those officers to be backfilled so that they can actually access the vaccine. Our department's internal communication staff, within the Office of Public Information, has developed and implemented a robust communication strategy. We really communicate with staff through emails, posting of information on DOC TV, posters, flyers, and also the intranet portal during our roll call, talking about the vaccine and the availability of it. And we make sure that if someone does express interest in getting the vaccine, we ensure that they have access to do so. So one of the things that we also do is provide information regarding eligibility, frequently asked questions, instructions on how to receive the vaccine on Rikers Island or within the community at the various borough vaccination sites. And also working with the city's vaccine command center, we've had 3 town halls dedicated to DO staff, specifically touching on questions that DOC staff may have. And we've also publicized information regarding 5 other town halls so that people can participate in those as well. I can tell you I have attended all of those town halls and they've been providing a lot of information. One of the things that we continue to do is provide also frequently asked questions throughout on our internet, working with DOHMH. People have questions about the vaccine and we continue to make that available to our staff.
Thank you. And Steve or anyone can respond, but I want to just speak to our dialogue. And I think part of our dialogue is not about critiquing or blaming or identifying shortfalls. Our questions are about understanding and even pushing and encouraging to do a little better. There's no question that I don't think anybody on this board thinks that what has happened in DOC, the way it's been handled, has been an absolute disaster. We've had some victories, we've had some successes, but I think the questioning of the board, and I'm not speaking for the board, but I'm articulating my experience of the dialogue that I've had with various board members and the questioning. It's really about trying to understand and to encourage and to push and to collaborate so that, yes, we could do a little better, or yes, that we could think a little differently. Yes, so we can think outside the box. So at the end of the day, what we all want, we want officers to be healthy and safe. We want detained people to be healthy and safe. We want the administration to be healthy and safe. And we want our communities to be healthy and safe. That together, by asking these questions, by thinking outside the box, by pushing all of us to do a little better or to do a little differently, that we may all end up with a result that we have healthier communities, healthier institutions, and healthier staff. So I would encourage all of us. The questions may feel like it is a criticism of your efforts, but I would encourage us to listen to the questions and to not think about them as criticisms, but think about them as how can we be doing things differently. And I would encourage any board member, if they want to speak to it, or DOC or CHS.
Stanley, thanks. Every word you said is how I feel.
Thank you. So we're gonna move on to visiting. I think we covered. Meg, is there anything that we need to cover on testing or vaccines?
No, I think we covered all of it. And on visiting, we touched on this in January, and we're working on scheduling a meeting with DOC to talk about visiting more specifically, but just wanted to give them an opportunity to talk about the televisits and, or broadly, where they are on the reopening plan, again, taking into account this entire conversation. So I just wanted to give Dana Wax an opportunity to provide a quick update.
Sure, good morning. So as described at last month's meeting, the department has created a plan for in-person visitation that incorporates DOHMH's 4 core principles, balancing safety and social distancing with an opportunity for meaningful in-person connection. Meg, as you've mentioned, I know we have an opportunity to talk through additional questions related to in-person visitation last week, and I look forward to that conversation. Ultimately, as the board is aware, the city's percentage of positive tests remains as a citywide average at approximately 8.5%, although it is not safe to reopen visitation at this time. We stand ready to do so when it can be done safely and appropriately. I'm happy to answer questions about televisiting.
Yes, a quick question on reopening visits. Is it the city's 7-day average that DOC will be using as the benchmark to reopen visiting and services, or is it the department's 7-day average?
Sure. So we can certainly talk about this in a little more detail later on in the week. But we have worked with DOHMH to come up with both internal and external metrics to make sure that we are guarding both the people who are in our custody and also with consideration for the fact that reopening visitation means people from the community would be coming into the to the facilities.
Got it. Any other board?
What is the capacity for televisiting right now?
No, I appreciate that question. So I know that was an issue that was raised last meeting as well. And in response to that concern about capacity and demand, the department undertook an audit of approximately 1,000 requests, televisiting requests from the same day each month in November, December, and January. What we found was that 93.2% of the requests resulted in a televisit scheduled within 2 weeks. Of that remaining 6.8%, a majority of those were not scheduled due to an error on the part of the person submitting the request. They had perhaps requested a day or time that's not available, or they misspelled the name of the person that they were looking to visit in a manner that it was not possible for the department to determine who they were looking to visit. So based on that 93% success rate, we feel very confident that we have the capacity needed to provide televisits to people in custody.
Just to follow up on that, would it be reasonable for you to have a greater goal, like 3 days for a televisit? I mean, there's no transportation issues involved in here. I mean, why not? Wouldn't it? When people ask for a visit, are they asking for a visit in 2 weeks? They're asking for their hope would be to have a visit sooner than that, I would assume. What would it take to get a visit within 2 days, say, in terms of capacity?
Well, when we created the system, also recognizing the fact that visits only run on the visit schedule, they run on a 5-day-a-week schedule, and so I don't have information for you right now about what it would look like to change our process to that extent, but you know, certainly something we can continue to think about.
Well, I would just say that we should assume that we're in this for a long time, and therefore we should try to create. This is not a criticism, Dana. This is just a way of I'm encouraging myself to think about this, and the department as well. We should, you know, we all value visits for all the same reasons, and having visits 5 days a week, two times a week, whatever the the current agreement is, should be the goal. And I think the department should look to create the capacity to get visits within 2 or 3 days, not 2 weeks. And I would look forward to hearing from you on that capacity. It's great that people got visits within 2 weeks, but that's not enough. I think we'd all agree.
This is Jack. I have a question, if I might.
Yes, Jackie, please.
I'm interested. Thank you for the information and the presentation, Dana. I'm interested in knowing how the department is soliciting and accepting feedback regarding visits that do occur, and how that feedback is being tracked, you know, be it about quality, about technical issues, or anything else with respect to the visits that occur, and what you've learned today regarding the visits from that feedback.
So thank you for that question. I believe that the evidence of the fact that we have had so many requests for these televisits, my understanding is by the end of 2020, we successfully operated over 33,000 televisits. That, you know, that really does speak to a process that is working. I believe a preliminary review of grievances related to televisiting found that less than 0.5% of grievances had to do with technical issues. So again, that was certainly a preliminary review. So I appreciate your question, and it's certainly something that we can continue to talk about.
Thank you.
Thank you. Any other board questions? Okay. Thank you, Dana. We're going to move on to the update on the Polanco report. Meg?
Yes. 1 second. I'm having a little technical difficulty. On June 23rd, 2020, the board released a report presenting findings and recommendations in connection with its investigation concerning the death of Layleen Polanco. Ms. Polanco died in the restrictive housing unit on Rikers Island on June 7th, 2019. She was a 27-year-old Afro-Latinx transgender woman. The board's investigation is distinct from those conducted by other city and state agencies. BOC investigations do not focus on criminal wrongdoing or individual fault. Rather, the board's investigation focuses on the circumstances of deaths in custody and identifying where lessons can be learned to prevent future deaths. The board's report made 25 recommendations concerning DOC and CHS policies and practices. These include recommendations to transform the processes the agencies use to exclude from punitive segregation for people with medical or mental health issues, increase and improve information sharing between NYPD, DOC, and CHS while protecting sensitive patient information, enhancing and retraining DOC and CHS, retraining on DOC and CHS policies for housing area rounds to ensure staff identify people at risk, and institute new oversight over medication provision to encourage proper access and compliance. The board has requested the department and CHS provide an update on their progress in implementing those recommendations. And so I'll turn it back to the board. I believe Bobby and Steve have some questions, and we can open it up to the rest of the board.
Thank you, Meg. Steve, do you have a question?
Sorry, you were breaking up, and I couldn't hear the whole thing.
So I just walked through sort of broadly what our recommendations were, and that we're just looking for an update from both the department and CHS on implementing.
Mm-hmm.
Good.
Yeah. So if you have questions, or we can open it up to the other board members.
Yep. Bobby, Steve, any questions?
Yeah. Sorry, there's some construction noise that's bothering me. I'm sure you more. The report recommended an action plan for DOC to develop regarding interpersonal conflicts in the special consideration units. Has the plan been developed? Our concern was to minimize numbers of transfers that we observed in our review of the Polanco matter. Another question is, when individuals must be rehoused from the special consideration unit due to conflict, has the department updated policies for required staff housing options aligned with individuals' gender identity, including placing transgender women in GP units with cis women transferred to a men's facility or de facto isolation? And could you update the board on the status of our recommendation that a formal policy be issued on how new admissions are operated for transgender women, including time limits and placement criteria, as well as what has been done to label units like the SCU new admission system to enable better oversight so that the board can follow this the information regarding movement into and out of those areas.
I am the Director of LGBTQ Initiatives at the Department of Correction. I'm going to answer the first part of that question about mitigating conflict on the unit. So much of what we've implemented is a result of conversations we've had with people with lived experiences, advocates, as well as those who are currently in custody. So within those conversations, what we heard a need for and implemented were weekly community meetings on the special considerations unit. And those meetings are run by our counseling unit, and we have now implemented having a member of our PREA team join those meetings. And within those meetings, they have the opportunity to discuss issues that are happening interpersonally on the unit. They have an opportunity to discuss individually with the counselor if they do not feel safe sharing it with the group. And they also can discuss any PREA issues that they may be having on the unit, as well as just physical housing unit issues if, there's issues with showers, TV, phones, etc. And I am provided the notes following up from every meeting. So if there is any necessary follow-up that has to be done on my end, I'm able to do so. I also have now been sitting on what is called our supportive services meeting. The supportive services meeting discusses individuals in custody who may be in need of some further support due to behavioral concerns. So I'm able to provide insight in regards to those who identify as LGBTQ, as well as, again, provide any necessary follow-up support to that specific individual. We have also implemented an LGBTQ hotline. So this hotline is accessible to by the housing unit phone to anybody in custody. So this allows LGBTQ people to call and directly speak to an LGBTQ unit staff member, and they can discreetly discuss their concerns with individuals on their unit, any concerns they may have, any questions or needs that they may have. And then again, all of these calls are responded to by an LGBTQ unit staff member. I also review all the calls, and we provide our follow-up, any necessary follow-up, within 48 hours. Similarly, to allow for even further discretion with concerns or needs that may be happening for LGBTQ people in custody, we've also implemented an LGBTQ services form on the tablet. So this will allow an individual to fill out the services form, which has a list of numerous services we provide, as well as a blank space for any concerns that they may have outside those necessary services, in a completely discreet way where they can fill it out without ever having to vocalize it, without the fear of somebody overhearing on the unit. Those forms are sent directly to myself. And again, we try and do all of our necessary follow-up within 48 hours, unless there's exigent circumstances. We also, in hoping to create supportive environments with it throughout the entirety of our facilities, we have just implemented a Pride Ambassadors initiative. And that is where individuals on DOC staff, both uniform and non-uniform, can volunteer to become a Pride Ambassador. Those individuals will be a visual support network for LGBTQ people in custody. The visual support is by a Pride Ambassador's pin that they will wear on the lapel of their uniform or their daily, outfit if they are a non-uniform staff member. These individuals are going to be will be specially trained in order to respond to the LGBTQ community, as well as they will be assessed at the end of their training to ensure that they have the necessary skills and knowledge, and they will also be available for their peers. That's another big piece. If their peers have questions on how to best serve the community, how to answer questions, they will be a visual support for their peer network as well. And lastly, we have also developed a discharge planning guide for LGBTQ individuals in custody. This was developed and also reviewed by the board's TGNC MBI task force. And this is just resources, most common resources that are requested by LGBTQ people in custody. It's been distributed throughout each facility.
Hi, thank you, Liz. This is Dana Wax. Unfortunately, I can't get my camera to turn on, but I really, appreciate what Liz just shared with everyone about the work that we are doing to move forward, and also the way that we are incorporating the lived experiences of the of people who hold trans identities to move our programming and policies forward. I did hear a question also about new admissions, and I think Tricia Feeney, DC Feeney, will be best suited to answer that part of the question.
Good morning. It's my pleasure to tell you the changes that we've made to not only how we deal with conflicts in the SCU, but our housing of transgender individuals when we get applications from the SCDU. We have formalized the committee who makes the decisions based on housing. Director Munsky, who you just heard from, is on the committee, as is DC Beal, along with myself, James Riley, who is our newly hired SCA for PREA, Assistant Commissioner Yalardi, and other folks in the department who specialize in housing and custody. When a determination is made and the new admission housing time period has elapsed, then the person would be housed in with business days. The 3 business days used to align with our new admission housing, but now with COVID, folks spend more time in new admission housing. If an individual is in EMTC, but they have been approved from Rose M. Singer, I send an email to SCA Bush to see if we can get approval from the medical staff to complete the new admission period in Rose M. Singer. What we have done when there is conflict in the unit is myself, Mr. Riley, our ACUR, as well as the PREA team goes to the housing area with the facility administration to try and resolve whatever the conflict is so that the individuals can remain in the housing areas where they are. If an incident occurred that would require infractions and other movement, it's discussed among the committee members. And jointly, we make a decision as to where an individual would be transferred. We do our very best to kind of leave everybody where they are. But if we feel that that's not appropriate, then we will find appropriate housing for anybody who is involved. Additionally, the PREA staff check in with every transgender person in the department every week, regardless of where they're housed. So this has helped us in identifying issues and problems before they become a real issue or a problem. If necessary, we can address whatever issues that are raised with the facility or bring in other units or resources if necessary to handle the issues.
Thank you very much. Appreciate it. Appreciate that report.
You're welcome.
Any other board questions? Thank you, Dana. Thank you, Elizabeth. We're going to move into our final discussion before we go to public comment, which is CHS reentry planning. Meg?
Yep. I'll turn it over to CHS's Assistant Director for Reentry and Transition Services, Ellie Epstein. Thank you for being here, Ellie.
Thank you so much for having me. Good morning, everyone. It's a pleasure to be here, and I appreciate the opportunity to speak with you about some of the services we provide. I do want to be mindful of time. I know that a couple of board members expressed needing to leave, so I'm going to try and move quickly through this and just offer a brief overview this morning. But my contact information is on the last slide, and I sincerely encourage everyone to reach out to me afterwards if you have questions or concerns or suggestions. So with that note, slide please.
Next slide.
Thank you. So the 3 core principles of the services we offer are first and foremost centering patient autonomy, a focus on the continuity of healthcare, and the need to be resourceful and flexible with all of our plans. Slide.
Next.
I'll just say next. So in terms of centering patient autonomy, we put patient choice and consent at the forefront of all of our activities, and that means actually having to respect when patients aren't interested in receiving a service. That said, we recognize that over the course of an incarceration, people's circumstances change and their feelings about working with us might also change. So to that end, we do periodically reoffer services and make it a point to constantly be offering education about what services are available. Finally, sorry, I should say though, that does sometimes mean that the onus is on patients actually to make us aware that they're now interested in engaging or in receiving a particular service. And then finally, I just want to mention that we do also require patient consent before we share information. I'm just flagging that because as having been on the other side in the community, I recognize that sometimes can feel frustrating as it may seem that we're withholding information. But I just want to express that that's also very frustrating for us. We're not always able to be as forthcoming as we might otherwise choose to be. But again, that's because we want to respect our patients' decisions at the center of everything we do, particularly being mindful of the setting that we're working in. Next. So as a healthcare provider, our discharge planning services are designed first and foremost to facilitate continuity of care in the community. And as such, the core services that we strive to provide for everybody are an offer of a Medicaid application if necessary, providing medication post-release, and at a minimum, making sure patients are aware of where they can go in the community to receive care. In addition to the core services we offer everyone, CHS also provides individual discharge planning for patients who meet specific criteria. So that includes folks who are living with HIV, people receiving mental health treatments, and people with particularly complicated care needs, such as stage 4 cancer or on dialysis. We have a handful of different teams who assist with discharge planning. If there are advocates listening, you might be familiar with some of our alphabet soup, which I think, again, on the outside sometimes seems confusing, but does mean that patients are working with CHS staff who are experts in the particular of their care and have an awareness of the programs and providers in the community that may be best positioned to serve them. I also think it's important to acknowledge that in addition to our efforts, DOC also provides reentry planning services to the general population, and that there are many community organizations, particularly Fortune Society on island, who also offer assistance with reentry. Next. So for Medicaid, about 50% of our patients have Medicaid coverage, and some number also get coverage through other sources. For everybody else, we strive to offer and complete a Medicaid application pre-release, and a lot of our efforts recently have actually been focused on moving up that offer of an application. So increasingly, we're able to make that offer at time of intake, and we're hoping to do more of that in the future. Next. As you may know, when patients are incarcerated, their coverage goes into a suspend status, and it gets reactivated upon discharge. That process is automated. It takes about 2 to 3 business days and is controlled by the state. CHS is in regular communication with both HRA and the State Department of Health to try and QA that process and to advocate expediting reinstatement. That said, we are aware of cases where patients' Medicaid coverage is not automatically reinstated. Sometimes we get calls from patients or community providers making us aware. When that happens, CHS provides assistance with documentation and requesting manual reinstatement. I also want to mention that we're able to provide care to all of our patients post-release, regardless of insurance status, at our point of reentry and transition port clinics, and we also offer Medicaid applications at those sites. In addition, CHS contracts for Community Reentry Assistance Network, better known as CRAN services, and they have locations in all 5 boroughs, and they're also able to complete Medicaid applications. I'm going to return to both those programs a little later, so I'm going to park it for now. And then finally, I just want to mention that we do have agreements with HRA's Public Engagement Unit and Metro Plus to support post-release outreach for Medicaid enrollment and recertification. Next. So ensuring that patients are able to continue taking their medication upon release is incredibly important to us, and we attempt to facilitate that a couple of different ways. So we actually implemented a new discharge notification process, which flags for DOC patients who are on priority medication so that they can bring them to clinic prior to their release so that CHS can provide medication. In 2020, we provided walking meds. That means literally like pills in hand for over 1,500 patients. In addition to walking meds, we also provide prescriptions to community pharmacy of patient's choice when they let us know where they'd like them sent for everybody who's on medication at time of discharge. And in 2020, we did that for over 2,800 patients. Finally, individuals on methadone receive coordinated linkages, including arranging for courtesy dosing to community treatment providers, and we did that for over 1,000 patients in 2020. Next. So CHS also created a reentry helpline called Portline, which is actually staffed by some peers with lived experience and is available to assist with a range of different issues. One of the services that group provides is for folks who do let us know what their community contact information is, They call post-release to follow up and remind patients about where they can pick up their medication. They also are available for troubleshooting or for requests to reroute scripts. And this is something that's come up actually a lot with COVID, as people's housing circumstances have been more precarious, or they find themselves needing to isolate someplace they originally didn't anticipate. For patients who are on psychotropic medication, we provide medication grant program cards, MGP cards, which is a state program that actually covers the cost of those medications. Finally, we're able to provide medication at no cost to those without insurance coverage through our port practices. CRAN is also available as a payer of last resort, and we often do this for a stopgap measure, for example, over weekends, or for patients whose Medicaid hasn't been reactivated yet. CRAN is able to pay directly for medication. Next. Okay, so I know I've mentioned them a couple of times, but our port practices, our point of reentry and transition practices, are clinics we created in partnership with H&H Office of Ambulatory Care. And we currently have two, one located at Bellevue Hospital, one at Kings County. And there are a couple of features that I think make these clinics really exciting. So one, we have incredibly flexible appointments. We have on-site peer support, and we're staffed by physicians who are incredibly passionate about choosing to work with this patient population. And that includes some of our own CHS doctors, which has been really exciting because actually in terms of continuity of care, it doesn't get much better. We have some folks who have the advantage of seeing the same clinician both pre and post-release. And we've heard from folks that they really appreciate that service and the fact that they don't have to keep going through the same questions or tests again. These clinics offer primary care and connections to the entire gamut of H&H services and specialists. And our Bellevue clinic actually now also offers in-unit or in-clinic psychiatric care. And that's been particularly helpful for patients with long-acting injectable medications, which has been a challenge that many folks encounter, particularly in the acute reentry phase, where getting an appointment isn't always an immediate request. So finally, I just want to say, although obviously great affinity for our port practices and H&H family, we do also assist patients through CRAN and Portline with making appointments and selecting providers outside of the H&H network. Next. So for patients who do work with CHS staff to receive personalized discharge planning services, we help them identify a provider and schedule appointments prior to their release. And we also facilitate placement into residential treatment for patients who are interested in that. We're beyond the port practices, as I mentioned, we've been working with H&H, which has been one of the major advantages of the transition over into H&H, to better facilitate transitions into their system. Next. So for patients who could benefit from additional support and are interested, we also make referrals for care coordination and case management services. I do want to specifically flag CRAN. As I mentioned, that's a service that CHS contracts for and offers kind of two flavors, if you will. The transitional case management services are available for patients with serious mental illness, and case managers follow patients both in and out of custody. However, I want to really highlight this because I think it's important to note, and I think there's a lot of misperception given how long CRAN services have been in existence. We actually opened the other CRAN services to all patients. So historically, these services were only available to Brad H class members. Again, they're now available to anybody who's been in the jail system. So that includes assistance with benefit applications, assistance getting your medication, referrals for care, education, employment, housing assistance, whatever it is you need. CRAN is available in all 5 boroughs to provide that service. And then, of course, we're also lucky to have so many other amazing partner organizations, including Fortune Society, Osborne, and Exodus. Next. So although continuity of healthcare is our main focus, we're incredibly aware of the importance of meeting patients' other needs, both because of their impact on health, but quite frankly, because they're often of greater priority and concern for our patients. To that end, CHS completes SNAP applications for Brad H class members pre-release, which is possible because of accommodations made by HRA, and can assist all patients post-release via CRAN. We also complete cash assistance applications, support SSI applications, and make referrals to jails to jobs. Specific to COVID, we actually provided technical assistance to patients in custody applying for federal stimulus payments. To support housing, we complete 2010E applications, coordinate DISH placements, HACA placements. We make referrals for transitional housing to home base, And unfortunately, when we exhaust everything else, we do make referrals and try and do a warm handoff to shelter. Specific to COVID, we've been making use of the Mopj hotel sites, which have been an incredible resource. And I particularly want to thank Exodus, if anyone's listening, who have been incredible partners. And it's been amazing to be able to make that kind of a warm handoff into safe housing for patients. And it's made a real difference for some of our most vulnerable folks. With respect to identification, CRAN is available to assist with securing birth certificates, IDs, and retrieving property. We know this is a major challenge and a priority for many of our patients, and so actually we've been advocating to bring IDNYC on island for years. So we're incredibly excited and enthusiastic participants of the new task force that the Mayor's Office of Criminal Justice has convened on this issue. Next. So discharge planning for individuals in jail has always been challenging, largely due to the unpredictable nature of release. And contacting our patients post-release to follow up and ensure that services and connections were made has also been challenging because many of our patients either don't have or don't feel comfortable providing us with reliable contact information. COVID has obviously presented new challenges. So although we support the efforts and are incredibly enthusiastic and thrilled that so many of our patients have been released, it has been challenging to provide discharge planning services to so many people at the same time, particularly in a context where providers have changed their availability and modified services in the community. Beyond the formal services that we can arrange, we also know that our patients rely on their friends and family members for support and are sensitive to the fact that many are members of communities which have been disproportionately burdened by COVID. Next. So as I mentioned, we love when patients get released. So in addition to trying to prepare patients for reentry, we also actively advocate for their release. In 2020, we sent almost 3,000 letters for patients to support their release on the basis of clinical risk. And we also provided court advocacy services for an additional 1,700. Next. We do think that our work matters and makes a difference. For patients who get a plan, 74% remain in the community for at least 3 months post-release. Next. So I just want to close by highlighting a couple of changes that we've made to our services, specifically in response to COVID. So the first of which was actually implementing a brand new discharge screening process. At time of discharge, DOC produces patients to CHS so that we can screen, asking about any new symptoms which are commonly associated with COVID, and assessing folks' ability to isolate in the community. Anybody who reports new symptoms or is COVID positive at the time of discharge and indicates that they don't have a place to stay, CHS will offer to make hotel arrangements and coordinate with DOC for transportation. Next. For anybody who's released prior to their PCR test result being returned, CHS makes every effort to follow up with those who've had a positive result. In instances where where we are able to connect with a patient, we actually are able to put them on with a CHS doctor who discloses the results and discusses that with patients. And then Portline staff are available to offer services, including accommodation. All cases, regardless of whether we're successful in connecting with the patient directly, or get reported for follow-up tracing. Next. Portline staff are also available to provide information about community testing and vaccination sites, although I do want to just emphasize that we're not able to directly schedule to those sites. So I do want to flag that for everyone. For patients who've received the first dose from CHS of the COVID vaccine, but get released prior to receiving the second dose, Portline staff are actively outreaching those folks in the community and making arrangements so that they can receive their second dose. Next. And finally, I just want to say I'm very sincerely proud of the work that CHS does, but I also recognize that that's only possible because we have fantastic partners in the community. So to all the providers and advocates, if you're here, if you're listening, sorry I can't see you, but sincerely, thank you so much for the work that you do and for your partnership. We really appreciate it. We strive to be good partners, and more than anything, we just want to ensure that our patients are cared for both while they're in custody and on their return home. And so to that end, I just say, if there are ever questions or concerns, or as I said, suggestions, I'm very sincere in inviting you to contact me. We are open-eared. Thank you. So on that note, I'll open it if there are any immediate questions.
Thank you so much, Ellie. Any questions from the board? You're on mute, Bobby. You are on mute.
I'm so sorry, I still can't, yeah.
Bobby can't unmute.
Bennett, is there, do you have,
Okay.
there we go.
Okay, there you go.
Ellie, I just wanted to thank you so much for that presentation. I learned a lot. It's a credit to you and your colleagues in the department for providing these necessary services. Really great. Thank you.
Thank you so much. That means a lot.
The one question I have, Ellie, could you speak to the collaboration between CHS and DOC? DOC also has a number of discharge planning activities. How do those two entities, how are y'all coordinating?
Yeah, absolutely. Thank you so much. So a couple of things. One, I actually want to highlight I feel a little weird saying this. If there's a silver lining to COVID, I will say actually it's been in some ways the collaboration, especially on reentry. So arranging for transportation, for example, to programs and to hotels has been incredible. On a sort of more routine basis, again, as I hope I emphasized, we do see our discharge planning services as fundamentally different in that our core responsibility and our expertise lies in our role as healthcare providers. And so I think the orientation that we're bringing to that planning exercise is really oriented around health and making sure that patients are able sort of to meet their most obvious and concrete healthcare access issues. So for example, making sure they have insurance coverage, medication, they know where they're going in the community for care. And then recognizing that as that kind of moves outwards, that includes things like making sure people have access to safe housing and food and things like that. I do think the DOC discharge planning services are oriented really around the general population, frankly, as opposed to sort of some of the specialty cohorts of patients that we've identified. And they often work in complementary fashion. So I do know, for example, that the DOC discharge planning often has much more of an employment orientation than, for example, our services do. I also think that for patients in the facility, the frontline staff actually are very familiar with each other. So in cases, and it's not so common, but in instances where patients may be receiving discharge planning services, both from CHS and from DOC, there's often conversation happening between those frontline workers to make sure that people aren't, making completely different plans that don't actually work together.
Thank you. Any other questions? If no other questions, thank you, Ellie, again for this presentation. We appreciate the work. We're going to go into public comment now. I have the list of speakers. I'm going to call speakers 3 at a time so people can have an opportunity to turn on their video and get ready. When you hear your name, please raise your hand using the hand icon below the participants list on your WebEx screen. If you don't see the list, click on the silhouette of a person on the menu at the bottom of your screen. Once you open the participants list, you should see the hand icon in order to raise your hand. When you raise your hand, we will unmute you and you will be able to turn on your video. You can then begin your public comment. I will tell you when it has been 3 minutes and we will move on to the next speaker. Again, the board welcomes written comments. You can email your written comment to boc@boc.nyc.gov or mail it to 1 Center Street, room 2213, New York, New York, 1007. I'll now call on our first 3 speakers. Melania Brown, Ellie Cruz, Ashaki, and Tone.
Hello, everyone. I'm not sure if you guys can see me. I don't see the icon for the camera anywhere. Can you guys hear me?
Yes, we can hear you.
Okay. My name is Melania Brown. I'm an activist and sister of Leilene Polanco. My sister died on June 7th, 2019 in solitary confinement alone. It's no secret, and it's no surprise that solitary confinement has been overdue to be shut down before our time. Our ancestors was fighting this long before we even stepped foot on this earth. If it would have been done by then, my sister would have been still alive. She would have, many of our loved ones would still be alive and with us today. I'm sick of coming over here on this meeting just to find out what's going on because you guys don't keep me informed. That's not fair to me nor my family. The mayor made a promise that solitary confinement will end by October of 2020. We're still here today and it's not on your agenda. Still, every meeting that I come on, I look forward to hearing about solitary confinement finally coming to an end and you guys voting on it. And I'm just hearing a recommendation of other things. Let's not get it twisted here for 1 minute. Yes, solitary confinement killed my sister simply because she was who she was and simply because of her gender identity. But let's not get confused here. If solitary confinement would have been ended, it was never in place to begin with, my sister would have been here today because you guys would have never had a box to throw her in. It's not fair to me that I walk around with my sister around my neck while coming to these meetings just to hear recommendations and nothing yet is being done. My only regret that I have in life is not fighting my sister's oppressors while she was alive. Not doing this while she was alive, because she would have definitely been with me today. I'm going to continue to show up. I'm going to continue to fight for my sister. There's no backing down. I am not scared. I am not scared. I'm standing 10 toes down, waiting to see what you guys are going to do. Internal punishment to the CEOs that watched my sister die. They literally were laughing. I released a video. You guys all seen it. I released a video and all they get is a suspension. I mean, with a pandemic, all that is a vacation. Like, let's be serious here. My sister deserves more than that. My family deserves more than that. We're now living with a painful life sentence. It is not fair, and it is not fair. And I'm gonna call out Taisha, Elias, the Cruz family. I know sometimes it gets hard to come up here and face these people. I know it's hard sometimes to speak up because that pain that you're holding inside won't let the words come out. But I will speak for you too. I will speak for your family too, and my family, and every other family member or someone to the hands of the government. I don't care what these inmates have done. It is not our job to judge them. The higher power, the only ones that could judge is God, is Allah. Okay, everyone sitting in this meeting right now, the BOC, the DOC, all of you guys that can't see me, I wish you guys could see my face. But all of you guys sitting on those chairs have done something that you guys have not let no one else know. Nobody is one of your deepest secrets. So when you do decisions and you decide to throw another human in a box, think about yourself. Think about you being in that box, because we're not perfect. But it's your job to make sure that these inmates they go home in one piece to their loved ones. It's not your job to throw them in a box. It's not your job to use solitary confinement for COVID, for simply a gender identity. Come on, COVID. You guys are using it for COVID. Some people come back and their tests come back in 5 days that they're negative, and they still got to remain there for the whole 14 days. It's being abused by the CEOs. And yeah, the CEOs, they come here and they talk about, all you guys talk about is the inmates and not about us. The CEOs are going to be put in danger if solitary confinement is shut down. Well, guess what? I watched 3 CEOs laugh while my sister died. So I'm sorry that I have no sympathy. You guys should be well trained to do your job without hurting someone, without throwing them in a box to be rotten and left alone to die like my sister did. And I will continue to show up. And I know my time is up. I'll be back next time. You guys have a good day.
Thank you. I see Ellie.
Hi, can you hear me?
Mm-hmm.
Hi, my name is Eliel Cruz. I'm the Director of Communications at the New York City Anti-Violence Project. We're an organization that works to end violence against LGBTQ people, and we have been the organization behind the advocacy for Layleen Polanco. Personally, it has been my honor to support the family of Layleen Polanco with media advocacy to ensure that her story remains on the national stage. I don't have prepared remarks. I have been coming to these meetings since October, hoping that solitary confinement would end, and it's quite mind-boggling to me that we have month after month after month it not show up on the agenda. And I have sat here for hours and hours listening to families of those who have been lost inside of your jails and just pour their hearts out. And at the level that the BOC moving at such a glacial pace, I just don't understand if the gravity of these stories are actually landing. and this is a draining process for me to sit through, and I can't imagine what these families are feeling. I mean, I can imagine some because I'm actually speaking to them, I'm actually talking to them. I also want to bring up Taisha Cruz. It has been 4 months since Christopher Cruz has died in Rikers, and they still do not know what happened to their brother and son. 4 months? That's just it's beyond comprehension to me. And these condolences, are appreciative, but also feel very empty when they're not even communicated to the family, and they're copy and pasted. And every time the New York Post writes a new article about someone dying in jails, so I have questions. My question is, when will actually the solitary end? I know there was a very quick update. It's still very confusing to me, as it was clearly to people on the board here who haven't seen the rules. So a public statement with that process and timeline would be incredibly helpful, so that the families don't have to come here and find out for themselves and sit here for hours on end. Taisha Cruz couldn't come today because she was working. It's ridiculous. And answers to what happened to Christopher Cruz, so the family can get some type of closure. In a year that we're experiencing such intense grief, we can't give the family some answers as to what happened to their loved one. It's absolutely ridiculous. And the report on the update of the Layleen Polanco report, the LGBTQ director of the DOC ripped through some updates. It was hard to understand and catch them all. A public statement, or at least a report to Melania, to the family, to let her know what has come from their sister, her sister and daughter's death, would be helpful. If it, from the quickness of it, it didn't seem quite substantive to say we need pride ambassadors with a pin to answer to that. It signals that there are other correctional officers who are not pride ambassadors. Is that an admission that they are not friendly or perhaps hostile to LGBTQ inmates? I hope that is not, the end of the updates for this report, but those are, more information, more transparency, perhaps moving with a sense of urgency because people's lives are at stake, and some more empathy, because right now it comes incredibly indifferent.
Thank you. The next speaker, I don't see her. Ashaki. And after Ashaki, it's Mike, Harmony, and Sarita. Okay, I see Ashaki.
Good morning. Can you hear me? Good morning. Every month I share with you, the members of the Board of Corrections, inmate advocacy groups, and the public, the daily challenges New York City correctional officers face behind the gate in the facilities. On April 24, 2020, in a Daily News article, the mayor of New York City, Bill de Blasio, expressed that forcing correctional officers to work 24 hours during the coronavirus outbreak was a dumb managerial mistake, and it will not be allowed from this point on. For the past several months, the New York City Department of Corrections continues to force correctional officers to work 24-hour shifts daily. Some correctional officers are working 30 hours with no food, no water, no breaks to take medication, or even to take care of their personal hygiene. Last Saturday and Sunday, correctional officers remained on post for 4 straight 8-hour tours. Again, no meal relief, no food, no water, no call home to check on their families. To add insult to injury, correctional officers are not paid for these mandated hours worked. Inmate services are disrupted due to staffing levels, and in turn, they are turning their aggression out on officers in the housing areas. Inmates are threatening officers and at times physically assaulting them because of the lack of services received. It's a vicious daily cycle which has created a hostile environment of uncertainty. Let's talk about fatigue. How can one possibly perform their duties effectively when you're tasked to work mandated 24 hours, most times 30 hours? Correctional officers are not getting rest. Why are we repeating the mistakes of the past as it relates to officers working in excess of 24 hours? Why is this acceptable? There is an expectation that all correctional officers are to be treated humanely. The same applies to inmates who are incarcerated. Where's the accountability for those officials responsible for this failed policy? Where's the plan of action to ensure correctional officers go home after completing their 8 or 16-hour shifts? The inmate population has drastically increased. It's increasing daily, roughly about 5,200 inmates. The inmates accepted into DLC custody are more violent and are in custody for violent crimes committed outside of a jail setting. It is irresponsible to release inmates who commit violent crimes for the sake of reducing the jail population. This action is a direct smack in the face to the victims of these crimes. Compared to last year, approximately 1,400 correction officers are actually less in the Department of Corrections.
Thank you.
Wait, I got 2 minutes, 1 second, and I'm going to close up. The housing areas are filled to capacity. EMTC should no longer be an annex to AMKC. EMTC should be open independently as it permits and assists for social distancing. The majority of the housing areas at EMTC are open. COVID has not disappeared in the facilities. Assaults on officers has not disappeared. Over the weekend, a female correctional officer was punched in the face. Yesterday, 2 female officers was punched in the face. We have to do better. So again, it has proven that all parties involved in decision-making choosing to make the excuse of financial restraints over the health or safety of officers who work in the facilities and the inmates who are incarcerated is unacceptable. Resources are made to protect the public outside of a jail setting.
I'd like to ask you to submit your testimony, but we got to move on to the next speaker. I appreciate it, but we have to move on to the next speaker.
We need a new class, Mr. Richards. We need correction officers hired. That's what we need.
Okay.
Thank you.
Thank you. Our next 3 speakers, Mike Kincaid, Harmony Seberg, and Sarita Daftry. Okay. You may begin.
Mick, you're muted. Bennett, is there any way to help from your end?
Oh, thank you.
There you go.
Okay. Thank you for helping me with the technology as well as letting me speak today. There's a lot of information at this meeting, and I don't have prepared remarks as some of it wasn't made public until right now. So I'm going to try and respond as much as possible. My name is Nick Kincaid. I use he, him pronouns. I'm a staff attorney for the Legal Aid Society, as well as a member of the Jails Action Coalition and HALT, and also on the TGNC&B Issues Task Force. In particular, I want to address the fact that everyone has mentioned, whether they're on a pro or a con stance, that there has been an increase in desperation within the city jails. Units are being housed at above 50% capacity, and the response to that has been that that's just simply how it has to be right now. There's been a discussion about how people in the city jails are folks who have committed violent crimes. That simply isn't true. From the numbers, we know that over 4,700 people are there awaiting sentence. So they actually haven't committed anything. They're awaiting justice. The majority of people who are being held in the city jails are actually not people who've been charged with anything at all. And I think that's really important for everyone to remember. And also important as we focus on decarceration, that there is always more we can do to advance decarceration. I'm really heightened to see the CHS numbers about how often they advocate for people to go home. And I think that kind of attitude is exactly the attitude we need if we're going to actually help meet people's needs and ensure people don't come back to the jail system. That said, I think a lot of the trauma that people are experiencing right now, both because of COVID, because of overcrowding, because of understaffing, because of lack of transparency, is really making things increasingly hard for folks on the island and for their families and loved ones. I worked with a trans woman who just recently was moved from Rose M. Singer to a men's facility, and she was held there for the weekend in the men's facility. She experienced an assault. I did advocacy for her. I know 2 other organizations did advocacy for her. She was eventually moved back to Rose, but I still have no answers as to why she was moved there in the first place and why moving a woman from a women's facility to a men's facility was considered appropriate in this context. I appreciate the updates that were given, but it seems that it still is an option on the table that women could be in men's facilities depending on their behavior. A cisgender woman would never be placed in a men's facility because of her behavior. It's baffling, and I think is genuinely extraordinarily disrespectful, and I think it makes a lot of sense as to why sometimes people don't completely trust the updates or trust, we're talking about like vaccine, for instance, why they might not want to get vaccinated when they also know that they're not seen as full people in the eyes of folks who staff the facilities. And so there's a lot of trust to be rebuilt there if this is to be anything close to approximating justice. Finally, I just want to say that I really applaud the idea of ID NYC coming to the island. As someone who does reentry work with legal aid, IDs are the #1 questions we get questions about. I have a young trans woman. She came home in March because of COVID. She still hasn't been able to update her social security card because of a lack of access to IDs. Obviously, the pandemic has made this harder, but she was sent home with no IDs. We had to work from scratch, and in New York, that's very, very difficult to do, considering you need an ID to get an ID. And so as one result of this, she still hasn't gotten any of her stimulus checks, meaning that she's living still in poverty on the streets. But she is eligible for them, and if there'd been more work to do around her discharge and to connect her to correct planning and help, she might already now be off the streets and have her money that she is deserving, as we all are.
Thank you, Mick. Thank you. Harmony?
Hello, thank you. I would like to yield my time to Dr. Victoria Phillips.
Think she has to get queued up. Let's go with Sarita. Oh, she's queued. Okay. Ms. V?
Yes. I don't see me. Can you hear me? Can they hear me? Hello.
Yes. Yep.
Okay.
We can hear you, and we can see you.
Thank you. Peace and blessings, everyone, and thank you, Harmony, so much. I'd just like to follow up with what Mick was discussing and talk about really quickly. First, I would like to know if BOC is doing its city charter mandated job of oversight by tracking delivery of second dose to people who received the first dose of vaccine. So I would like at the next meeting, could you get back with that information to me? Also, when we talk about the vaccines, I think, as a brain surgery survivor myself and someone with autoimmune disease, I think it's important that we not only advocate for people to have access to the vaccine, but what does that look like with side effects? I was talking to a medical provider, a doctor last night regarding side effects from the prison population and jail population. And one of the minor side effects is just needing Tylenol. But when you think of a correctional setting, individuals can't walk to their medicine cabinet and get Tylenol. So what does that actually look like? For major side effects, what does that look like? Who's monitoring them? Who's following up with them? You know, this is the anyone behind the walls could have a serious issue, let alone someone who already has preconditions, right? And then lastly, I just want to talk to you about this COVID. I've told you last month, one BB and on the boat was COVID filled with 3 or 4 people that DOC staff reached out to me because they wasn't being informed. Within 3 weeks, 6 or 7 units now have COVID individuals on the boat and other facilities on the island. And I just want you to hear from someone directly who recently had surgery, who wasn't even followed up on when we talk about procedures and COVID and medical necessities that aren't being addressed.
Tuesday, February 9th, 2021. So I had surgery on my foot on the 20th. I still have not had any home care for the home. I found out I had stitches because I had to take a shower. I went 6 days without showering. I couldn't do that anymore. I was trying to wash them to see. Found out I did got stitches. It started sticking. Once my home started leaking a little bit, sticking to the gauges and stuff. So once it got wet, I was able to take it off. I saw that I had quite a bit of stitches. It's been over 20 days still. No hear anything. My foot is getting better. I'm able to touch around and stuff now. I did request for neurologist. I don't know why I was taken out of the system. There goes my paperwork. And it's been a counselor. I had copies and she emailed it to staff here who got into medical. And ever since then, I've been waiting to go back to the neurologist. Still have not. As well as physical therapy. I went one time when they started back up. And all of a sudden, I was taken out of the system. So I'm still waiting for that.
So I know that there's many other people that want to speak. And so I just really want to say that just as much as CHS, and I hope you're still on, just as much as CHS wants to be commended on their work, and I totally agree, it's a hard job behind the walls, especially in DOC's space. But you have to hold them accountable, not just for COVID practices, but for all practices. The reason we put them there and took horizons out is for them to do their job. And when someone is in a medical housing unit and it's not even being properly followed up after surgery, I question everything else they've said to you today that they're going to do when they aren't even doing the basics. Peace and blessings.
Thank you, Ms. V. And Ms. V, could you let us know what housing location that gentleman was in so we can follow up?
Okay.
Just email us. Thank you. Sarita?
Hi, can everyone hear me?
Yes.
Yes, okay, thank you. My name is Sarita Daftry. I'm a co-director with Freedom Agenda and also a member of the Jails Action Coalition. So I want to speak briefly on a couple of things. One, the situation at RNDC right now. I heard from multiple people about concerns about the conditions there under the new warden. A woman described that she heard from her son that the new warden only wants to keep them on lockdown. Her son has been handcuffed and can't use a pump. He's asthmatic. And also mentioned that the warden who was removed was the only person who treated the young men there like human beings. So I just want to flag as this board's role in overseeing the management and discipline practices of the department, that a federal monitor continues to note that the department cannot manage to deliver timely and appropriate discipline to its employees, but has managed to reassign a warden who reportedly acknowledged the humanity of people in custody. It seems like the efforts at culture change are going in the wrong direction. In terms of video evidence and the board's responsibility and ability to the public, we know that people are being assaulted in the custody of the department on a basis. We received a couple of calls recently. Tuesday, January 23rd, around 3:40 p.m., a man was beaten unconscious in GRVC, apparently by the same guard who beat him up during a previous period of incarceration about 2 to 3 years ago. On Tuesday, January 26th, in RNDC 6 Central Cell, a correction officer broke a young man's hand. These are exactly the type of incidents that the board should be proactively reporting out to the public, because without you, no one will ever know. This is not the police department where there's public eyes on the street and still they're them accountable. The other thing that I want to speak about, death investigations. There was a lot of discussion about death from COVID, and the sort of acknowledging some success in preventing further deaths from COVID since the spring, but people do not only die from COVID in the jails. Any death in a controlled environment where a person has no liberty is a murder, including suicides. I think Dr. Safier said on the issues that will predictably lead to unnecessary deaths, we need to get together and we need to act, or something along those lines. All of the deaths in custody are preventable. All of the people who died in custody in the past year and before that was preventable. The mother of a person in custody said of her son this week, he sounds so frustrated, desperate lately. He's having asthma attacks due to emotional problems. Now, would the department determine his death? If it were to happen, I don't even want to say that. Would they determine that preventable? I would say yes, it was. The board has the ability and the responsibility to conduct investigations for every custody. The only reasons that any officers were disciplined for their misconduct that led to the death of Lilian Polanco is because this board did an investigation. The board has the ability to share with the public video evidence of when officers use force against a person in their custody, and the DOC has either failed to take swift disciplinary action or has deemed the use of force justified. The public deserves to form their own opinions about if that force is justified and how they feel about huge amounts of tax dollars being used to pay for that use of force. But unlike videos of police uses of force that have gone viral since the summer, the public never gets to see those.
Thank you.
Thank you.
Thank you. I'm going to call on the next three: Bridget McCarthy, Nas, and Miss V again.
Can you hear me?
Yes.
Okay, so Bridget and I will be presenting parts of the same testimony. So if possible, can I go first?
Yes. Yes.
Thank you. Good morning, and thank you for allowing me to testify today. My name is Naz Akil, and I'm here with the Urban Justice Center this morning to read my client's testimony about his experience in restricted housing. I just want to note that my client's testimony is a little longer than 3 minutes, so when I run out of time, my colleague Bridget will finish presenting it in her allotted 3 minutes. I will now begin reading my client's testimony. I am 28 years old and I grew up in the Bronx. I love to write poetry, make music, and cook. I'm currently being held at Manhattan Detention Complex. I was transferred here from OVCC on Rikers Island in early July. I've been incarcerated since May 2019, and for most of my incarceration, I've been in various forms of restricted housing, including enhanced supervision housing and the box. In my housing unit currently, we get strip search when we go to and from all areas of service and programs, and if we refuse, we are forced. Directives are not being followed because strip searches are not done at random. They are done routinely in a targeted way and to deter us from going places. Sometimes I am not allowed to leave my cell 2 to 3 days at a time, even to take a shower. When I file grievances, they are not addressed. The same thing happens with 311 calls when I make a complaint about the facilities. The complaint is never investigated, and officers forge log entries that say I refuse to cooperate with investigations. I do not have adequate notice or documentation detailing my restraint status and why I have been placed in restricted housing. In other facilities that I've been in, there were programs and social service groups that I could participate in, times I could go outside in a more open setting, and levels of the housing unit that were less restricted that I could move on to with time. For example, at ESH, there were different levels, and with good behavior, I could be moved from the high restrictive level 1 to the less restrictive level 2, where I had more entitlements. Ultimately, I could even return to general population. This gave me hope and incentive. But at MDC, I have no idea about the time frame of my confinement in restricted housing. There are no programs or housing designations, and there's nothing to look forward to. I am refused access to information about the rules and procedures that govern my confinement, without which I'm not able to adequately represent myself at due process hearings. Sometimes I'm not even allowed to go to the hearings to defend myself. I'm refused access to departmental directives and housing area rules that would detail my entitlement to minimum standards and basic rights. This creates a deeply embedded, unwritten policy of rights violations. I am often told about rules that do not exist and forced to comply with them without proper documentation authenticating the existence of these rules. I feel completely isolated and hopeless. I do not get to interact with anyone except for the one person I share my cage with. Being in restricted housing makes me feel very angry and sad, and I often hear things, and I often get very depressed and frustrated. I will now stop and let Bridget continue. Thank you.
Hello, I'm Bridget McCarthy. Can everyone hear me? Yes, I will be continuing where Naz left off. Being in the box during my current and previous incarcerations has affected me. When I went home before my current incarceration at NDC, I had a very hard time adjusting. I did not want to be outside. I only wanted to be by myself. When I got placed in level 1, the most restricted level of ESH housing, in December 2019, I felt suicidal and I cut my wrists. Even then, I was not sent to the mental health unit. No one took me seriously. I have been diagnosed with bipolar disorder, borderline personality disorder, and depression. I do not get to meet with a mental health official very often, and when I do, the meetings are very brief. By the time I get comfortable enough to talk, the meeting is already over. I am on medication, but I sometimes still have suicidal thoughts. I feel like I have nobody to talk to and no one to get help from. While in restricted housing, corrections officers treat us detainees with less care and more hostility, and they provoke us with fearful, disrespectful behavior. When I express these thoughts, I automatically get disregarded. I feel like I am missing out on so much, and I have no one on my side anymore. Recently, I have been subject to over 20 instances of use of excessive force by emergency services unit personnel. I have suffered serious injuries during these instances, including a broken nose, a dislocated shoulder, a dislocated knee, and a laceration on my forehead that left a scar. I had to be taken to the hospital for my injuries, and I have been told that I may need surgery for my knee. My housing unit has been targeted by ESU officers over the past weeks, and the number of physical assaults has skyrocketed. These assaults happen for the smallest, most trivial things. There is clearly discrimination going on because my housing unit has been under 24-hour surveillance by ESU, and they specifically pick on everyone housed in my unit with increasing frequency. I want people outside the jail to know that this is happening and that everyone involved knows about this targeted violence. Thank you for your time.
What unit was that? What unit was your client in?
Yes, this was MDC.
Thank you. So after Ms. V, we're going to have Kayla, Simpson, Jessica, Julian, and Victor Pate. Ms. V?
Peace and blessings, everyone. And once again, thank you, Harmony, for yielding your time earlier. So I just want to say before the person I was speaking about before, I just want to make note that even though they're in a medical unit, there are actually 46 people in that unit right now. I know that was brought up today with CHS and DOC, but I want to take this time because like so many people call me first thing 8 o'clock when the phones got on because they knew this meeting was occurring today. But I want to take some time to play a message from someone who actually covered several things that were addressed today.
Okay, so there've been a number of things in here, like as far as when it comes to the food, the chicken that they be serving, sometimes it's not clean properly, and then sometimes the food is not cooked all the way, or the food, like the celery is molded or just dried out. You got we ran out of toothpaste for a while, and toilet paper, and for like 3 days straight. Commissary shortage. There's barely anything on there. Sometimes it's nothing worth even getting. They run out of toothpaste sometimes on the commissary too that we can buy. When we go to rec, sometimes it be really cold outside, and they basically don't give us the option to use the gym on the inside rather than go out into the cold weather when it's snowing, raining, or it's just too hot. The lower library, the lower library, sometimes it comes, sometimes it doesn't. Same thing with the mail. The mail doesn't come like it'll come like 2 days in a row, and then the rest of the week it just won't show up. They won't pick up anything, and our mail be sitting in the box for a long time, and we don't even get certain things. I had my people send me 2 days shipping, and my thing is my stuff will be here the next day that they mail it, and I won't get that until a week later or two. Also, we barely have any cleaning supplies. We have a shortage sometimes on that. We're still overcrowded in this dorm. It's still at least 30 plus people in here. When it comes to searches and body searches, and when they come into the dorm, they're not wearing any gloves or latex gloves. New latex gloves, they'll be wearing the same gloves that they carry on their person from outside, and that's not sanitary or clean for us. There's showers in here that be flooding all the time and out of order for weeks at a time. I don't understand why that even happens. There's 30 plus people in here. We need to be able to take a shower. What's it called? We barely hear from our lawyers sometimes. They're not reachable, and we have to leave messages. Judges are not granting bills or lowering bills for people first so that we can afford it to get out of this situation. Let's see. The sheets, as far as what we sleep on, is very rare. It's like once a month they come in, we replace the sheets, and when they do, the sheets that they are given to us are stained and dirty or just not washed, period. And with our washcloths and towels, we get that once a month maybe.
So once a month for washcloth and towels, showers still overflowing. These are all conditions that will fester and spread COVID. Now, mind you, one building within 3 weeks spread to 6 and 7 units from our last meeting. These are all conditions, and Commissioner Brand earlier said we complain about small things, but these small things make the bigger picture, the bigger issues. So please make sure DOC is doing their job, because we're in a pandemic, and all of these things will increase the spread of this disease. Thank you.
Thank you, Ms. V. Kayla, Jessica, and Victor.
Hi, can you hear me?
Yes.
Wonderful. Good afternoon. My name is Kayla Simpson. I'm a staff attorney at the Prisoners' Rights Project, the Legal Aid Society. It's good to see all of you. Thank you for hearing me. First, Legal Aid Society client Laylene Polanco, excuse me. You know, the conversation about what happened to Ms. Polanco should convince you to immediately make public the conversation about what should be in the restrictive housing rule. You cannot allow this discussion to stay behind closed doors any longer. You have to have it in front of every stakeholder, not just the ones with an interest in diluting the change that they promised. And we've already been through this in the first rulemaking process about restrictive housing in 2019. People keep dying in the jails, but the way the jails use isolation and deprivation is not just about death of the body. When we don't learn these lessons, like about what happened to Laylene, but about what happens to everyone else, even the people who don't die, we will be certain to lose more lives, more hearts, more minds. We need to have the conversations about what actual progress looks like, and we need to have it in public. Please release the proposed rule as soon as possible so we can do that. COVID. We filed a lawsuit last week to push Governor Cuomo to authorize vaccine access to people in DOC custody, just as he had for other government-operated congregate residential settings. And we are thankful to CHS for the advocacy they've done on this issue and how clear they are that the nature of the correctional setting is itself a risk. And Dr. Yang is quite right. We did quote her, and we thank her. But we're concerned to hear, as Dr. Safier said, that the mayor does not appear to share this clear-eyed view. He dodged 2 chances given to him this weekend to join the call his own medical staff are making. He wouldn't do it. And it's not the first time. He did the same thing about the question of housing area density of jail population within the city jails, and the question of whether the city faces an urgent need to decarcerate. The clinicians in the jails employed by him are clear on this. The population levels are rising. They're at the levels they were at the beginning of the pandemic. It's dangerous. It makes their jobs harder, and the need to decarcerate is urgent. But I think what I want to get across is that this urgency isn't getting across. The people who hold the levers of power are not moving them. And I think I just need to bring to this space that what I hear in the voices of the people who call me, and I feel the need to do it because I hear even the commissioner of DOC calling the questions that the board is asking, picking at little things. And that is really difficult for me to hear. And I cannot imagine how difficult it would be for a person in custody to hear that the experiences that they're having are little things that are wrong, right? This pandemic is still raging. There were 34 new infections over the weekend. Can you imagine what it would be like to be sitting in a dorm in AMKC and see people removed from your housing unit left and right because they're sick or they received a positive test, you assume, because no one is telling you anything, and all you want to do is take an additional test and hear what your test result is because no one is telling you that. You assume that you're negative, but you don't know, and you have to ask for masks, and you're not sure whether you'll get a new one, and you're not sure when the next time that your laundry will be brought to you and if that person will be sick. Can you imagine having that little control over your environment during this moment? The voices that we're hearing from the leadership in the city are either wholly inadequate, they're silent, or they minimize. The commissioner called it little things. These aren't little things. 20%, every week, 20%, the board reports, of the entire jail population is in a housing unit with a COVID designation. 20%. It means they've either been a confirmed exposure or they're sick with it. That is completely unacceptable. And the carceral machinery in the city just keeps rolling. Judges, prosecutors, all perfectly willing to act as if COVID's not a real threat to people in city custody. And I bring this up to you, and I know I'm over time, but I bring this up to you because it just makes your voices so important. This isn't okay, and we have to keep sounding that alarm as loud as we can in public and in private. So your voices are so important, and we really appreciate any advocacy that you do. Thank you.
Thank you, Kayla. Jessica?
Hi, can you hear me?
Yes.
Great. So my name is Jessica. I'll be reading the testimony of someone currently incarcerated at OBCC at Rikers. I'm 28 years old and I was born and raised in Manhattan. I know New York City like the back of my hand. I've been homeless my entire life. I was a regular street kid growing up. 10 years ago, I was diagnosed with schizophrenia. I was arrested in August of last year, so it's been 6 months incarcerated for me. This is my first time incarcerated, and I'm still learning about how things work here. Right now, I'm in enhanced supervision housing. The building I'm in was actually the former box, and it's set up almost the exact same way the box is. It seems like it's impossible to get out of here. I've been here almost 4 months. They treat people really bad in ESH. I've been sprayed in the face with mace. The mace is incredibly powerful. It gets inside your sinuses and respiratory system. And it affects you psychologically because once you get to the point of blindness, you start to panic. In general, when mace is in the air, you know it. The staff also write false reports. They plant things on you that aren't permitted inside the jail, like metal objects. That happened to me right off the bat. In ESH, anything the staff says goes. Sometimes ESU, a special search team, is sent to our cells to look for contraband. They look like GIs. They wear full military gear, steel-toed boots. When that happens, it's intense and overwhelming. In ESH level 1, the staff really violate your privacy. Every time you need to leave the floor, they want you to squat, cough, check your mouth and ears. It's really uncomfortable. I try to just get through it as quickly as possible, but it feels like a violation. It's also hard to get your basic needs met. Just the other day, it was impossible for me to get a drink of water. The sink in my cell does not turn on. And I don't have any water at all. I can't get water because the COs aren't making their rounds like they're supposed to. And it's worse lately because they're super short on staff. The other day we locked out late, but they still wanted to lock in at the regular time. That's time ticking away from us. I've been able to get some medical care for a foot injury in ESH, but I haven't really gotten any type of mental health treatment. I've talked to a couple of people really briefly, but it's hard to create rapport, especially right now. I'm starting to realize like I'm going to be incarcerated for some time. Every day I wake up and it hits me, I'm in jail. That's hard to deal with and hard to talk about. I hope they can bring back programs for us. Right now, there's nothing to look forward to. No programs, no nothing. Every day is the same. There's no way to keep track of time. I got to the box on maybe my 10th day of being incarcerated. They gave me 20 days of time. By now, I've been there 3 times. When I'm there, every day just drags on. The cells are very small. We're not allowed to have commissary, so we spend the day starving, waiting 4 or 5 hours to get food. We have to be on the gates of our cells, shouting out, asking to be fed. It makes me feel like I'm competing with my neighbors just to survive. And I know I'm at time, so.
Yes, thank you. And you can, as I said, you can submit that testimony to us and it will be part of the record. Thank you, Jessica. Victor, and after Victor, we're going to have Michelle Garcia, Susanna Waldman, and Kelsey Davila. Victor? If Victor is not on.
I'm sorry. I was unmuted. I'm here.
Okay.
Can you hear me?
Yes, Victor.
Okay. Good afternoon. How you doing? All right. Thank you so much, and thank you for everybody who gave testimony and the family members of those that's incarcerated. So my name is Victor Pate. I'm a New York statewide organizer for the Halt Solitary Confinement Campaign. Formerly incarcerated person, a survivor and healing survivor of solitary confinement myself. And thank you for the platform. So I'd first like to say that, Halt Solitary Confinement Campaign has been working on ending solitary confinement with our Halt Solitary Confinement Bill for 8 years now. And also in 2019, we submitted a blueprint to the city for how they can end solitary confinement. And of course, in 2020, Bill de Blasio mentioned that they was coming up with this working group that was supposedly come up with a blueprint of how they were going to actually implement the ending of solitary confinement. Of course, that has not happened as of yet, and still we don't know when. So it's continuing delay when people continue to suffer in our prisons and jails. I'd like to say that, I find it kind of sort of like really disturbing to continuously attend, participate, hear testimonies from people that are directly impacted, collaterally impacted, family members of those who have been killed and or died while under the custody of docks and as well as state correctional facilities. And, we hear these stories and they're heartbreaking and heart-wrenching. And, the people who are responsible for making decisions on these policies is almost like talking to nobody, because you hear and you see the tears and you hear the hurt, the harm that has happened to families, their family members, as well as people that have been formerly incarcerated, such as myself. And it just hurts my heart to see and know that, nothing is actually being done except for a platform to hear people's pain. And I guess that's good for one part, that you have this platform, a measure of address to your pain and your suffering. But to continuously come back and tell your stories, to continuously sit there and hear of the stories of what happened and what is continuing to happen, especially with this time of pandemic and the horrors of what's happening in our prisons and jails, and things just don't change and nothing happens and no policies are being passed except, to me, rhetoric. And I think it is, well past the time for the human part of people who have the ability and the power to change this miserable system to actually do something and not just sit at a table and hear the pain of the people who have gone through the pain and the people who are feeling the pain. It's just really immoral. You know what I'm saying? It's immoral. I don't have any other words to say. It's just immoral. And I think that, what I'm saying, we as a people have a moral and a God responsibility to treat people humanely. Because, you know, we got to think about the very same people that we have in our prisons and jails now are going to be very same people that's going to be coming back to our community. And are they coming back broken? Are they coming back incapable of performing and contributing to our communities and to our societies? We don't want that. So in order for that to happen, restorativeness should be real. Redemption should be real. Second chances should be real. But if we don't change the policies as they are now and as they affect our prisons and jails and as it affect our community, then it's going to get worse. I'm a product of the 60s and the 70s, and being incarcerated in the 60s and 70s was bad. It's worse now. I would have thought that it would have gotten better by now, but unfortunately it hasn't. So I'm just hoping that these platforms that we have, and of course, thank you for this platform. I appreciate this platform, but I'm hoping that this just doesn't be a platform for us to give a shout out and a sounding board. I'm hoping that, you know, the stories that we hear, the policies that are being spoken to will actually begin to change, and that you people who sit at these tables who are in position to make these policy changes, that you actually do something. Thank you.
Thank you, Victor. Michelle, Susanna, and Kelsey.
Hi, can you all hear me?
Yes, we can hear you.
Okay, awesome. Just making sure. Good afternoon, everyone. My name is Michelle Garcia, and I'm a corrections specialist in New York County Defender Services. Here, I work directly with I'm advocating for our incarcerated clients. Today, I'm testifying regarding the pressing issue of our clients being held in custody after their conditional release or discretionary parole release dates. In the era of COVID, we should be working harder than ever to ensure that every person who is eligible for release from city custody is released. Yet, we are seeing our clients being held in past their intended release dates because DOC is not transferring clients promptly upstate. Prior to the pandemic, a client who received a state sentence would be transferred to an upstate facility within a matter of weeks. Soon after, the client would have their sentence calculated and be given a minimum release date and a conditional release date. A client's minimum date is when he or she is eligible for discretionary parole release. However, from late March 2020 to around early September, there was little to no movement between city and state Department of Corrections. When the pandemic hit, DOC explained that the movement between city and state facilities would cease and that the city corrections would not calculate state prison sentences. This led to several clients held indefinitely on Rikers Island, who otherwise would have been transferred directly upstate and then released. For the past few months, the NYCDS Correction Specialist Team has been working closely with a client on Rikers who has reached his minimum eligibility date. He is now serving additional time while waiting to be transferred either upstate or to receive consideration for parole while in DOC custody. We're now being told that if a client is past their full state or conditional release date, 2/3 of the maximum, then city corrections may be able to assist, and we are very grateful for this new policy. However, it still does not stretch far enough as it does not account for clients who would normally be eligible for parole and released at their minimum dates to the Department of Parole. Being held by the City Department of Correction prevents clients from exercising his or her due process right under the New York State Criminal Procedure Law. While we understand the Department of Parole determines who receives parole, this does not absolve DOC of the fact that our clients are being prevented from having their interviews because of DOC's refusal to move clients upstate or to present an alternative interview program. Committing parole eligibility according to the statute is vital to ensuring that our clients are given fair and just sentences. Releasing people at their latest eligibility dates constitutes a failure to evaluate potential release earlier on in their sentence. Logistical challenges caused by the COVID-19 pandemic are not sufficient reasons to deny incarcerated people the opportunity to be considered for parole at the earliest possible date. Today, I urge the Board of Corrections to investigate this issue and to work with the Department of Corrections and Board of Parole to ensure that New Yorkers are no longer held in past their parole dates because of unnecessary and foreseeable bureaucratic roadblocks to release. Thank you all for your time.
Thank you, Michelle. Next is Susanna. And after Susanna, it is Kelsey. Then it is Susanna or, okay, there she go. And
Hi, can
Kelsey.
you all hear me?
Yes, we can hear you.
Hi, I actually had requested, if possible, to go back to back with a colleague of mine because my testimony is also over 3 minutes. I don't know if that's possible. Her name is Claire. I'm happy to go later if that makes it more possible.
Oh, yes, I would. I was looking for Claire. Is she on now?
I believe so. Yes, it looks like she
Okay,
is.
yes, yes.
Okay.
Hi, can everybody hear and see me?
Yes.
Claire, you can start.
Thanks. Hi, so Suzanne and I are interns with the Urban Justice Center's Mental Health Project, and we will be sharing testimony from one of our clients who has been detained at Rikers. I am 46 years old. I grew up in Harlem. I've been incarcerated for 23 months on the current charge. I started at the Tombs, the Manhattan Detention Complex, and I've been moved around a lot. I'm now at the NYC North Infirmary Command. I'm a CMC, centrally monitored case, because I have an escape on my record from 1999, which I already served time for. This means I must be escorted everywhere I go. Food gets delivered to me. I don't go to the mess hall. I'm handcuffed and shackled whenever I go to recreation or anywhere else. There are cameras in the cell depending on how high the classification is. Right now at NIC, I'm in a gallery of 10 cells. There are 7 of us here. One cell is a shower. Another cell has a slop sink and mirror where you can shave. The whole tier area is only about 50 feet by 10 feet. There are 3 tables on the gallery, 4 seats to each table. Each cell is 8 feet by 8 feet, and everyone has an individual cell, but you're basically inside a cage. There is absolutely no social distancing. I try to stay at the edge of my cell to avoid people. I eat in my cell now. There is no date for me to get out of NIC. Once you're here, I'm here. You're here. I'm CMC because of an attempted escape that happened when I was around 26 years old. I was denied a hearing to challenge being placed in CMC for the escape. I never even left Rikers grounds. We were young kids, the back door of the dorm was open, and we went out and played basketball. That's why I'm CMC. Here at NIC, we are in cages during the 1 hour we are allowed outside for recreation. We don't have access to basketball courts. Now we go to single man cages. We didn't have a hearing for that, and you're supposed to have a hearing before you are required to spend rec in a single man cage. What gets me more than anything is the strip searches. I can't do it. I write it up every time and they get mad, but I don't care. Instead of fighting, I file grievances. They conduct visual cavity searches. They do it when they feel like it, once a week, 2 times a week, 3 times a week, as harassment and punishment. If something happens in another block, they come to us. None of us have been outside this building since February. There's no reason for them to even strip search us when they have a body scanner, hand wads, and x-ray machines. There are 7 cameras in the area they're in. There's no reason for them to strip search us when they already watch us all day, every day. If it's a fire upstairs, they storm upstairs and then they come and search us. They're stripping us as a punishment to embarrass us. They say, if you behave, you won't get strip searched no more. They come to your cell, 3 of them standing right outside your cell, fully dressed, wearing illegal motorcycle gloves with the knuckles that can hurt you, the leather gloves with carbon fiber over the knuckles. The BOC should check the Gentech video for the gloves they wear. They search us with the same gloves that they use with the detainees on asymptomatic tiers. They storm in our cell and strip us naked. I ask them, are you gay? You're about to see me naked. They get hostile and want to spray me with mace. I say, this is illegal. I don't consent. That's
Thank
what they, thank you.
Are you going to use some of, because you can submit the testimony and it will be part of the record, but I want to give Susanna 3 minutes, otherwise she's going to get 2 minutes.
Okay.
Okay. That's when they recommend, can you hear me?
Yes.
So I'm just picking up where Claire left off. That's when they wreck my cell, threaten me, put me through all kinds of chaos. I don't ever fight them back. The worst of the worst was when I was in the box at GRVC. Once you get in the box, they ignore you. You're locked in your cell all day. They don't care about you. It's no man's land. I was supposed to be on a liquid diet the whole time, but they didn't feed me. During the 30 days that I was there, I only had 7 pieces of bread. People light their whole cells on fire just to get attention and get out of the cell. I had 3 showers the whole time I was in there. I wrote down the dates. The only reason I got a shower was because I told the warden to check the videotapes, and she saw it was true that I hadn't showered, so she let me out. The second time I was able to shower was through the chaplain. I told them I'm talking to clergy, and she went and raised hell and got me a shower. Then a social worker got me out for the 3rd time. I stopped her, asking her to complain that I didn't get a shower in 2 weeks. When you first come in here, they strip you again. They have all the equipment there, so it's unnecessary. They take all your property. You're in there without a Walkman or anything. You get 1 phone call a day. If you wanted to call your mother and your lawyer, you couldn't. You have to call one or the other. In order to get the phone brought to you, you have to scream and scream for days. I was sent to GRVC for allegedly assaulting an officer. The crazy part is I had what is called a blackout. It is on camera. The Gen Tech never lies. I came out my cell, had a blackout, fell down the stairs, and had a seizure. They came for a medical emergency. I was thrashing. I don't know what was going on. I don't remember this. They said when they were trying to put me on the stretcher, I was lashing out and punched a captain. In the behavior report, it says it looks like I'm in and out of consciousness, don't know what is going on, and incoherent. And still, they sent me to solitary. After the seizure, I went to Bellevue for an IV. The seizure was stress-related. I've only had it twice in my life. At that point, I was at MDC, the Tombs. It's stressful there. You have a cell that doesn't open, you're just in a room, and it's locked by a steel door. It's miserable, gloomy. It's a seriously stressful environment. That's why they call it the Tombs. Each cell will remind you of a tomb you'll be buried in. After the seizure, there was a hearing to determine whether they could put me in the box, but they never even let me go to the hearing. I was railroaded. I included all of that in the grievances I filed. I said I wanted to go to the hearing. They said I refused the hearing, but there is no record to show I refused anything. The officer kept calling there, telling them I wanted to go, and then they put down that I refused. That's their tactic to make sure you get slayed on these misbehavior reports. You have to wait for someone to pick up and escort you, and someone writes in the logbook that you refused. In the box, they don't even pick up my mail, not my social mail or my legal mail. My lawyer has been trying to contact me for months and hasn't been able to. My visits have been denied. It took 4 hours for them to come get me when my fiance was here for a visit. And once they finally let me see her, a fight broke out in the visiting room, so I was trying to protect her from that garbage. The officers got mad at me for that, so they didn't feed me that night. And they held my fiance for 3 hours and wouldn't let her leave. In the box, they don't give you nothing. No writing utensils, no writing paper, no supplies, no cosmetics, no cleaning supplies, nothing. You go in a cell that someone just came out of. You won't be able to sweep, clean, or mop it. There's still feces on the wall from the last person who was there, toothpaste all over the walls. My whole first day there, I used my teacher and toothpaste to scrub the toilet and the sink because of the fluoride in the toothpaste. The Gen Tech cameras will show that my cell was flooded for the first 3 days I was there in January 2020.
Thank you, Susanna. Again, I would encourage you to submit that letter as part of the testimony. The full letter will be part of the record. And if you have these cases, give us a call and let us know where the person is, and we can look into some of those issues.
Okay, thank you.
Kelsey, and after Kelsey, we want to have Jennifer Paris, Kelly Grace Price, and Brad Mauer.
Hello, can you hear me?
Yes, we can hear you, Kelsey.
Hello, everyone. My name is Kelsey De Avila. I'm with Brooklyn Defender Services. At the January meeting and again today, Commissioner Brand was asked what the department was going to do to keep 50% capacity to ensure social distancing. Her response, which has not changed, is we don't have the resources. We know it's ideal for social distancing, but we cannot do that. The jail population is rising by 100 people a week, and there are consequences, like Dr. Cohen alluded to and that others have shared today. Commissioner Brand's admission is essentially that the department cannot protect people in its custody, nor fulfill their basic responsibilities to those in its care. This truth is in our face every day. People are wearing the same underwear for weeks, even months at a time because they are receiving only one pair. They're getting zero opportunities to have their clothes washed. People can't access recreation. Due process is delayed or more regularly denied. Masks can be scarce or not provided at all. People are missing family visits, legal visits, and video court appearances, an opportunity to advocate for their freedom. People are in units at max capacity, and the response from COs is, we don't have the staff, we don't have the supplies. And there are even times people in custody are confronted by staff who ignore their pleas altogether and have a complete disregard for the severity of the situation. And I'm not here to fault the department for not having the resources. I mean, we are witnessing the deep impacts of this pandemic. Staff are out sick, while some, I'm sure, are hesitant to come into work. But meanwhile, offices, agencies, organizations across the city and even country are rethinking how they approach their work while keeping their staff safe. And DOC should be no exception. The answer can no longer be silence and complicity, pretending like everything is fine and under control, because it's not. The jail population is rising every day during a pandemic with no concrete plans to address it. And we cannot do things the same way and expect a better outcome. You know, we learned this morning another life was taken by suicide, and it was insulting and offensive. The commissioner came looking for praise today. We strip people of their liberty, then we deny them their humanity, and look what happens. People are scared, people are isolated, and people are not safe. Decarceration is the most effective way to deal with the pandemic. We know this. Public health officials, including Dr. Yang and Dr. Ross, are telling us this. Yet we choose to listen to NYPD over them. Neither the mayor nor the courts have responded with the type of broad-scale decarceration that's required. We appreciate the board's letters, but more is needed. Be creative, write op-eds, put yourself out there and push back on this failed approach. We call on the department, the board, CHS to do everything in your power at convincing the mayor, DAs, and judges. More work is needed because we know jails do not keep people safe. CHS and the commissioner are telling us this repeatedly. So surely we can agree on this one thing, if anything at all. Thank you.
Chelsea. Jennifer?
Hello, can you see me and hear me?
Yes.
Okay, great. So thanks for this opportunity to speak. I spoke this morning and on other occasions about the need for policy change regarding isolation, but I want to speak now about lock-ins that occur despite policy, in violation of existing policy. I reported this specific incident to the board staff, but I'm bringing it to your attention now because there's a broader problem that the board and the department need to address. This incident involves a person who was locked in a cell at AMKC for 9 days. This man was on a mental observation unit, so CHS had recognized his need for a higher level of mental health care. He's a person who could not be placed in punitive segregation according to current board rules, but he was unilaterally isolated by the officers working in that unit. There was no disciplinary process, and during those 9 days, he was denied medication at times, he was in a cell that did not have running water, and he was denied showers. The situation this man described reminded me of what happened to Bradley Ballard. He's a person who died on a mental observation unit after officers locked him in a cell for days. The board needs to investigate the circumstances of this incident, but the department, CHS, and the board need to find a way to prevent these types of unlawful lock-ins. There must be immediate repercussions for the staff who make the decision to violate the lock-in rules, as well as anyone who is on the unit and doesn't report it. I also want to comment on CHS's presentation. I truly appreciate all they are doing to expand discharge planning services. And these services have improved in many respects. But unfortunately, services continue to be deficient for people with mental health concerns. It's distressing that people with mental health concerns now make up more than half of those incarcerated in the city jails. Now there are more people who receive mental health treatment in city jails than there were last year, despite bail reform. The quality of discharge funding services that people with mental health needs receive should be of concern to this board. According to the last monitor's report in Brad H., 41% of the appointments that were made were not appropriate to those individuals' needs. And those with a serious mental health need did not have adequate case management services in 28% of the cases reviewed, and assistance with supportive housing was inadequate in 53% of the cases. In addition, Department of Health, HRA, and CHS need to address gaps in the Medicaid reactivation system that results in some individuals not being able to use their Medicaid when they're released. Finally, I hope we will all advocate for people with serious mental health needs to be released into housing when they're discharged from the jail. The city has shown that in dire circumstances, it can set up hotels that address people's housing needs. The high rates of homelessness among people with serious mental health needs is a crisis, and it requires action by the city. And they should ensure that this population is not released into homelessness. Thank you.
Thank you, Jennifer. Kelly, after Kelly, our final two speakers will be Brad Mauer and Kelvin Howell. Okay. Brad Mauer and Kelvin Howell.
Hi, my name is, go by Grace, please, Mr. Richards. My name is Kelly Grace Price. I've never called myself Kelly. I'd like to thank the board. I'm from Close Rosies, and thank the board for voting down the ESH or any other advocate. Compliment you for finally getting a spine and voting down that horrible variance that's lingering. The board member, thank you so much. I want to quickly follow up on something that Dr. Cohen said last. People ramping up. I believe Dr. Cohen said last month there were 1,800. I need follow up about that. I would really like to know why so. Thing that shouldn't be brushed under the rug. The third thing I want to talk about, death of 2017. No, I'm sorry, 2018. He died. Who had a drug problem. He was in Florida, a drug program, and he needed drug treatment. CHS gave him a couple aspirin that belonged to a person caged. He had a reaction, a deathly reaction, and dragged him to the lab. Him medical care. It was what happened. Eugene's mother, Ms. Torado from Staten Island, is trying to get answers about the age of her federal civil rights litigation about her son's mysterious death on Rikers Island. And guess what? Of correction has lost the video of his death, or at least 2 hours of it. This has been detailed in the testimony and in the discovery conferences in the federal courthouse. And I believe the department has until today to cough up the entire version of the video. They had edited out 2 hours. Please go find that video. Please make sure the entire video makes it to the Torado lawyer. And please do not let sit there and pretend like she has everything in control when she's literally destroying evidence to be provided to the federal court. I hope there's an investigation into who destroyed the evidence, and I hope fingers point to the tippy top of the department's legal brass. I want to remind you that we've been asking for answers about this. Have a lot of deaths to answer to, and I would suggest you have a wholly separate hearing on this issue. Thank you so much for
Thank you, Kelly Grace Price. If you were breaking up, so if you would like to submit your full testimony so we can hear it, you were going in and out. So thank you. We have one additional speaker. So our last three speakers will be Brad Mauer, Kelvin Howell, and Brother Five.
Can you hear me?
Yes.
Just one sec. Thank you. So thank you. My name is Brad Mauer. I'm a staff attorney with New York County Defender Services, a public defender office in Manhattan. I heard Dr. McDonald say today that the situation in New York City jails now is different in many ways than in the spring. I agree with that. And the most obvious difference is the jail population, right? In the spring, it was down to levels we haven't seen since 1946. Now we're right back where we started in March of 2020. And the rate of the jail population's rise is only increasing in recent weeks. We're putting more and more people in jail. The consequence of this rise in the jail population is another big difference between the spring and now, and that is the duration of this new outbreak, the lack of being able to flatten the infection curve among the jail population. In the spring, we had about 570 people infected in the jail population. About 85% of those happened within the first month. Now, from November 17 to February 7, we've had about 406 incarcerated people newly infected. But unlike the spring, the rate of new infections continues to rise by the week. So much so that if current trends continue, the current outbreak will surpass the spring outbreak in total infections among the jail population in about a month. And we have zero reason to believe that the ongoing acceleration of new infections in the jails is going to stop, because we're doing nothing of consequence to bring the jail population down. And that's the final difference between now and the spring that I want to talk about. That the people and the institutions with power to actually do something about the jail population are failing. In the spring, CHS leadership publicly implored prosecutors, judges, and everyone else to reduce the jail population. DOC and the mayor's office agreed to release about 300 people serving city sentences under the 6A program, and judges granted many petitions for release that were brought by public defenders. Now, CHS leadership is telling the board in January that they feel like the alarm has already been sounded. They don't need to do it again. As of January 29th, over 130 people serving city sentences with no other holds, yet none of them are being released under 6A. And more than 230 people are in jail for technical parole violations with no pending criminal charges. And that number is rising right now, not falling. Now, of course, we have judges and prosecutors who are, judges are setting bail after prosecutors are seeking it. And that's one of the main drivers of the jail population, the main driver. And the Manhattan District Attorney's Office deserves special mention here, because recently my office has petitioned for the release of several clients with high-risk letters from CHS. In response to these petitions, the Manhattan DA's office has submitted legal filings in court with the following statements. Currently available data shows a consistent decline in the rate of infection among the jail population. New admissions represent the largest group testing positive among the inmates. The last time Rikers Island had so few inmates was in 1946. Spread within the inmate population continues to decline. It's clear that the Manhattan DA's office, based on these statements, is still living in July of 2020 instead of in the here and now. And judges are going along with it. Whether their obliviousness is willful or not, judges and prosecutors are not even acknowledging the facts on the ground right now. So to everyone with the power to do something about the jail population, if you think that you are muted behind the scenes efforts to push for decarceration or having a meaningful impact, you are wrong. We know that the failure to decarcerate will cause more disease and death in the community, and we'll be very lucky if more incarcerated people don't lose their lives as well. So I'm begging everyone with power to do something about the jail population, speak more loudly. It's not working. Thank you.
Calvin?
I yield my time to Minister Dr. V.
Thank you, Calvin. Is Miss V up? Or we should go to 5 while Miss V is queued up. 5?
Thank you very much. Can you hear me, board? Can you hear
Yes,
me?
we can hear
Okay.
you.
Thank you very much for your time and allowing this testimony today. Usually I'm on this in a capacity of Incarcerated Nation Network or one of our youth programs in our reentry services where we service so many people. But today I'm more in a capacity of the Test and Trace Board, in which I'm on the oversight board for. There is a lack of honesty within our city health systems. We are not addressing those with COVID-19 when they're released. I'm not sure where health and hospitals are getting this because it's different for us with Dr. Theodore Long. We don't have any responses. We don't acknowledge those in prison and jails. The infection rate is much higher than we want to admit of people returning home who are testing positive. The vaccines are not being shared equally. We have over 500,000 doses out. Majority of those people live in the suburbs and then use wrong addresses to address those vaccinations. It's a process that is happening. There is no direct service, and we still have people being placed in solitary as a punitive disorder. This is an airborne, very infectious with multiple strains disease. I say disease because we're combating it with mass incarceration. That is only leading to the higher deaths. We still have the Department of Corrections sending letters to upstate impacting people's paroles, stating that their time on Rikers were an allocated right when they're not supposed to be doing that. But I want to also remind this board that Rikers, solitary confinement, are all conditions of slavery. All right. This facility was built in 1650. That predates Auburn. That predates any correctional facility in the state and in America. We have a moral obligation, just like we finally admitted that we actually sold people as currency on Wall Street, that we're confining people for profit within the jail system, right? Every ticket makes the system financially paid. The sad part is that these are mostly, in the highest numbers of people of color. I don't even know what to do anymore, y'all. First of all, thank you, Dr. Cohen, for always being the vital voice of preserving and supporting human life. I just want to say that, Dr. Cohen. But this board, I've presented, I don't know what to do. Like, I have reports from the White House. We didn't have so much media. I'm working on 3 more movies. One of them is entirely about the board. What else can we do besides the constant deaths, the proliferation of people of color being forced into solitary as a punitive measure, and a system that increasingly lies, talking about everyone is violent offenders, and this is not even checked as the Board of Corrections allowed to lie on testimony. I'm kind of lost at what we're doing. I'm on this board of Test and Trace with hundreds of other medical professionals who are equally concerned. Nothing is being done. You know how hard it was to get Fortune involved when the city and health and hospitals in the beginning of this pandemic? Do you know how hard it is to get the city to admit to having weekend warriors? I'm not sure if you understand what that is. That is people who are sentenced to go to prison and jail at MDC on Friday and released on Monday. Still during the pandemic, nobody's addressing that. Is there a rapid testing available for people who are being released? People are being released saying no, it is not. We're even ready to set up a mobile station outside of Rikers and outside of MDC to address this because it's not being addressed. And so I wanted to bring a different sort of responsibility and remind this board that it's not only a medical responsibility to preserve life, but to look at the inequality of the entire city jail system, right? And I'm not talking about the 900 and something county jails within the state. I'm talking about just New York City, the exclusive locations that we have, right? We uniquely punish people of color more. That is the majority rate of people in solitary. People leave solitary. Of course, we know what a horrid amount of conditions. I live with them still myself today. But there has to be a moral obligation. Like, I'm so tired of these sort of trauma porn hearings where people are just pouring out and crying and people are literally dying. Like, how many virtual funerals do I have to hold within the city jail systems on 4 family members? And corrections is talking about security, profit, and their offices as if their offices' lives don't matter. The word inmate comes from New York State. And I know that I'm out of time. I just wanted to present a moral obligation as a test and trace oversight board member who test and trace in health and hospitals is not doing their job to save and prioritize Black lives. I couldn't even get Spanish guards and people who speak bilingual at Yankee Stadium. It is horrible. And so we are always put last, and it's sad that people of color will allow other people of color to be punished. And I think that there needs to be a medical, life-preserving priority within these hearings, especially about solitary confinement and isolated confinement.
Thank you, Fred.
Thank you for your time and your patience. And please address health and hospitals with the accuracy of their numbers, because I'm going to email you the correct data from Dr. Theodore Long, which is the head of Health and Hospitals Test and Trace Board.
Thank you.
Thank you.
If I don't see Miss V. Kelvin, do you want to speak? If not, that will conclude our public comment.
I yield my time to the gentleman that just spoke.
Thank you. Currently, inside of MDC, is the board concerned with weekend warriors? Do you understand the existence of weekend warriors and the structure of weekend sentencing? Has the board looked at the civil detainment units? Have the board looked at the entrance and the exit of people leaving the facilities and them coming back without some sort of testing or any type of COVID-19 support? Number two, the Board of Corrections should be oversight for not only abuse. As most of you know, I've spent time at Rikers, and because of my activism, I spent time in MDC. The airborne infection is impossible to contain, okay? Especially when you have a circulatory system of air that pumps into the cells and into the facility. This is why test rates will automatically increase. Number two, what resources, because there are none, so I'm challenging you to actually ask DOC, what resources are they providing for people leaving besides another organization being put on that? And what are we doing to deter weekend sentencing, right? I know the question and the answers to all of this is nothing, but I just challenge the board to look into that because that is your duties. Health-wise, we have majority people of color inside of incarceration in New York City jails. That is reports from the White House all the way up. But as far as test and trace, those are also the highest numbers of people infected. The highest number of people to respond to the vaccine, which is a whole nother level, because I took the vaccine on Friday. Saturday, I was immobilized. I couldn't imagine a person 65 or 70 taking the Pfizer vaccine without having major effects. Sunday, I still can't even taste. I can't smell. It is now a whole nother week going on, almost 7 days. I've filled out already a VAERS report. I'm working with the CDC to collect more data around adverse effects. But I couldn't imagine somebody 80 or 70 taking the vaccine and I did and having a tough time that I did. There is nothing set up for people incarcerated. We have a governor and a mayor that doesn't even list the deaths, doesn't even speak about people incarcerated on his daily TV show. We have a reality show in the city and we have a TV reality show in the state where people are being neglected. So the general population don't understand that these deaths occur. The people who are dying upstate, my clients, my 3 clients who died this week, Elmira, Auburn, there was another abuse, but also another confinement because of COVID-19 in Franklin Correctional Facility where the short shoes are being used. All of those people were sick when they were on Rikers and it wasn't addressed when they got sent upstate. And so the pinnacle, the feeding of the 62 counties, the 50 counties comes from Rikers Island. We know that. It is their duty to supply bodies to feed financially to upstate facilities. Those bodies are not even being serviced and were held in detaining longer, which of course affected their ability to enroll into programs upstate. We're the only state not doing this, but we also have a Board of Corrections that the mayor can say, hey, it's not on me. I have these morally committed people who are listening to professionals more than people who are directly impacted. You know, me and Victor Pate have been doing this for like a decade, right? When I came home in 2010, I was immediately remanded because I opened a nonprofit and did organizational work and organizing with people directly impacted. And that's the first rule on probation. Okay. Come home in 2012, we're fighting solitary still, why? Why are we allowing officials to come on here, promise data with unconfirmed facts? You have advocates who work in a system who testify against that. They're not listened to. How many times are we going to pour out our hearts about this? These are conditions that are killing our people of color, Black people mostly. And that is why I believe most people don't care. Now, I'm not going to put the Board of Corrections in the category that don't care, but there is a health liability that you're responsible for. We have to take lives seriously, and this board's duty, because, you know, we assassinated the last board for not following their duty, this board needs to adhere to human life preservation. And that means thinking about the racial message that you're sending, the inequality that New York State is representing, because New York State, of course, created the rest of the counties, right? People don't understand that. And understand the facts that the Test and Trace Board, and listen to those people who are on the board, like me, I'm on the advisory board, who have to listen to all these different CAB units complain about the same thing.
Thank you. Thank you.
It needs to be some moral obligations. And I want to thank you for your time. And as always, Dr. Cohen, I thank you for being the sound voice of preserving life and preventing more deaths.
Thank you.
Thank you.
So this concludes the public meeting. The next board meeting is scheduled for March 9th at 9 a.m. The meeting will be held via WebEx, and details will be available on our website, and we'll send an email to interested parties. I want to thank everybody for hanging in there and sharing your voices, sharing your experiences. Just really appreciate hearing from you. On behalf of the board, thank you. This concludes our public meeting. Take care, everybody.
Thank you. Thank you, Stanley.
Thank you, Stanley. Take care, everybody.
Thank you, Bobby. Thank you, Marco.
Thank you, Stanley.